Well, as we get the slide deck up, I will welcome everyone. Good morning and welcome to the 2024 Measure Set Review Recommendation Group meeting. I'm Brenna Rabel. I am a senior social scientist at Battelle, and I serve as the technical director for all of the consensus-based activities that we do under the Partnership for Quality Measurement. I'm so pleased to have you all with us today to help us carry out the very important work of reviewing measures to help CMS make informed decisions about its measure portfolio. Before we get into the discussion today, I would like to just take a brief moment to reflect and to thank our colleagues that are joining us from the southern US, especially North Carolina, in the wake of Hurricane Helene. Thank you so much for your continued commitment to this work, and please know that you are in our thoughts. For everyone on the line today, we are grateful for your participation and are looking forward to a productive and illuminating conversation. As I'm sure you all know, our aim is to help CMS take a really critical look at their cost and efficiency measures, to give them some food for thought and recommendations about which measures should be retained and which they might consider phasing out or replacing. All of your feedback is valuable, so please be sure to engage and speak up when you have something to say. So without further ado, I do want to just remind you about a couple of housekeeping items. You had seen the housekeeping slides rotating as you were joining the call today. We're just asking that everyone be on video throughout the day, especially during the discussions when you might be speaking. We ask that everyone use the hand raise feature or type your questions into the chat. We will be using the chat fairly frequently today to share links, occasionally to respond to more technical questions that don't require a whole group discussion and so on. So please be sure to be monitoring that. And then don't hesitate to email us if you experience any technical issues. We have staff standing by to monitor that inbox. It's the PQM support at battelle.org. And we'll be able to address your issues quickly there. I also just want to remind everybody about our community guidance. We just want to make sure that we are setting a tone that is collegial and constructive. And so with that in mind, we just ask everybody to come to this discussion assuming positive intent, taking care to listen actively and to make sure that we're respecting all voices and making room for all perspectives in the discussion. Regarding Zoom, again, if you have any technical issues, you can refer back to the slides, which we've shared a link to, or you can email us at the PQM inbox. One thing that's very important is that if you are joining this meeting as a measure developer or steward, please make sure that you rename yourself in Zoom so that your name shows as first name, last name, and then your organization in parentheses. So like my own name where it's Brenna Rabel and then Battelle in parentheses, please do the same for yourselves. This will help our team promote you to a panelist for the discussion so that you can respond to questions as they arise. Finally, we did include a list of acronyms. We do work in an acronym-rich environment. We tried to spell out the big ones for you in those housekeeping slides. We will do our best throughout the discussion to explain acronyms as we go along, but please, please, please don't hesitate to reference this slide or to ask in the chat for clarification if you hear something that's unfamiliar to you. Chances are, if you haven't heard it before, someone else hasn't heard it before, so it's never a problem to ask for clarification. Okay, now we can go back to the Battelle introduction slide. Thank you. So as I said, I'm Brenna Rabel. I'm joined today by Meredith Eastman, who you've already heard from many times this year, I hope. Meredith is the pre-rulemaking measure review and MSR task lead, and she and I will be co-facilitating today's meeting. You'll also see Jeff Geppert, who is our scientific methods lead, who may join to talk about any of the reliability results that you see or have questions about on these measures. Kate Buchanan, who is the deputy task lead for this work, who is going to be helping you go through the roll call and your disclosures. We also have Lydia Stewart-Arts, who has led all of these measure evaluations that you used with your preliminary evaluation. So she will also be online to help explain some of the criteria. And then, of course, Isaac Seichi, who will be managing all of our voting. We're also joined today by our colleagues at CMS, notably Dr. Michelle Schreiber, Helen Dollar Maples, Nidhi Singh Shah, Mel Gross, Charvan, and then all of the CMS medical officers and program and measure leads who do the work on the measures that we're going to be discussing today. And each of them plays a part in helping to understand why these measures were put in the programs in the first place, to help us understand what gaps they may be filling or any statutory requirements that they satisfy, and to help provide some context for our discussion. So with that, we can go to the next slide. Simple agenda for today. We are in the middle of our welcome and process overview. I'm going to be turning it over to Kate Buchanan after this to go through the roll call, and then Meredith will talk us through the process. We'll start reviewing measures right after that before breaking for a lunch around midday. Then we'll go through the rest of our measures that we have scheduled for today before we reflect a bit, adjourn, and plan for tomorrow. Next slide, please. All right, with that, I'm going to turn it over to Kate.
Thank you so much, Greta. Okay, we can move on to the next slide. So we asked you all to complete a measure-specific disclosure of interest form prior to participating in this meeting. I want to thank everyone for completing it. We had 100% response rate, so we don't have to mention anyone who didn't do it on the call, which is just a wonderful way to get it started. We are now actually going to go through our roll call, which is where we will verbally ask people to disclose their conflicts of interest. If you have a conflict of interest, and this includes serving on a measure TEP, you cannot participate in the discussion or voting for that measure, but you can participate in the voting and discussion for all measures not related to those where you have a conflict, including serving on a TEP. And before we get into going through the roll call, I did want to see if there were any questions about a conflict of interest or any points of clarification that we can provide. Okay, well then we can move on to the next slide. So I am going to start with our co-chairs, and then after we go through our disclosures of interest, I'm going to turn it over to Rosie and Akeen to provide some welcoming comments, but I am going to start with our co-chairs for their COIs. So Rosie, I'll start with you.
Sure, Rosie Bartell, and I have no disclosures of interest in this set of measures.
Thank you. Akeen?
Good morning, Akeen Demahan, American Hospital Association. Nothing to disclose. Welcome, everyone.
Thank you. Erica Alexander?
Hi, I have no disclosures to report.
Thank you. Nishanta Nund? I don't know if he is on. Let's see. We will have to come back. I don't see him on. And then we have Anita Mastorty.
Good morning. This is Anita B. Mastorty with APTA, and I have no disclosures.
Thank you. Rachel Blair?
Good morning. I'm Rachel Blair, and I don't have any disclosures.
Okay. Scott Cowan? Okay, doesn't look like Scott is on yet. Michelle Dardis?
Good morning, Michelle Dardis representing the Joint Commission. I have no disclosures.
Thank you. Christina Davis?
Good morning, Christina Davis, no disclosures.
Thank you. Thomas Fredrickson?
Hello, Tom Fredrickson, Society of Hospital Medicine, nothing to disclose.
Thank you. Sean Griffin?
Sean Griffin, nothing to disclose.
Stephanie Ledbetter?
Hey, it's Stephanie Ledbetter. I have nothing to disclose.
Thank you. And then after that, we have David Levine.
David Levine, Vizient, nothing to disclose.
Thank you. Jennifer Lundblad.
Hi, Jennifer Lundblad with Stratus Health, nothing to disclose.
Okay. Saima.
Good morning. This is Saima from Elevance Health. No disclosure. Thanks for having me.
Thank you. Amy Minnick.
Good morning, Amy Minnick from Geisinger Health System. Nothing to disclose.
Perfect. Vika Nair.
Good morning, Devika Nair, nothing to disclose.
Ethan Novikov.
Morning, everyone. Ethan Novikov, nothing to disclose.
Mark Paris.
Good morning. Nothing to disclose. Apologize. I'm having a problem with my camera.
No worries. Thank you, Mark. Corinne Rubin. I don't know if Corinne is on. May have to come back to her. Okay, back. Jessica Schumacher.
Jessica Schumacher, nothing to disclose.
Thank you. David Saddleworm.
David Seidenworm, I have to disclose conflicts on the 2 incidental findings measures and the headache and low back pain imaging measures and the CT with contrast measure.
Thank you, David. Karen Srinivas.
Morning. With the American Healthcare Association. No conflicts.
Christine von Reisfeld. I don't know if Christine is on yet. Nope. We'll come back to her then. And then Isis Sambrana.
Good morning. I'm Isis Sambrana from Jackson Health Systems in Miami. I have no conflicts to disclose.
Great. Thank you. And then I just wanted to, before we turn it over to Rosie and Akin, wanted to check to see if Nishant, Scott, or Corinne or Christine have joined us. Okay, we will get their verbal disclosures before they, after they join. So I'm going to turn it over to our co-chairs. Rosie, I will start with you.
Well, I just want to welcome everybody, and I think that we'll have a great day. I think everyone has filled out their pie, and that was a very informative. And if you have a question or a concern that you don't want to speak up, put it in the chat. As patients and patient partners, please, if you want to reach out to me, and say, Rosie, I'd really like you to bring this up, please do that. I'm welcome. I'm welcome to do that for you. Have a good day.
Thank you. Akin?
Thanks so much. Good morning, everyone. Really pleased to have you with us this morning and throughout the next 2 days. I know that these conversations can be pretty complex, but the input that we give to CMS on its current set of measures, I know is feedback that they take to heart. So honored to do this with Rosie and really looking forward to the next 2 days.
Thank you, Akin. So I'm now going to turn it over to Tracy Archibald, who will provide CMS opening comments, and she is the acting deputy director for Quimbic. So Tracy, I'll turn it over to you.
Thanks. Welcome, everyone. Apologies, Dr. Michelle Schreiber is having laptop challenges today, but hopefully that will be resolved as she's got a new one. We really are excited for today's events. I'm really happy to welcome all of you to the next couple of days. We're very eager to hear your input, and you've spent a lot of time looking through the materials and thoughtfully considering your recommendations. So appreciate all of your time and efforts over the next couple of days, and look forward to some really engaging discussions. So thank you.
Great, thank you so much. And then after that, I believe I handed off to the MSR process, Michelle. I'm sorry, Meredith.
Hi, good morning, everybody. I'm Meredith Eastman. I am the Primer MSR task lead at Battelle, and I'm going to talk a little bit about our process overall. Then we're going to focus a little bit on what's happening today specifically, and then we're going to dig into some reminders about what our evaluation assertions are, and then we'll talk about voting. So we can move to the next slide. So this is just a depiction of what our committee organizational structure is. So you can see here that we have 3 committees that are setting specific make up Primer, and we take we select committee members from each one of those three setting-specific committees to make up the MSR recommendation group, which is that little box there over on the left. Whereas the primer committees consist of an advisory group and a recommendation group each, MSR is just the single recommendation group. There's no advisory group associated with MSR. Next slide, please. So we select MSR from the primer committees based on our representation criteria to ensure a range of voices within the group. And, you know, it is inclusive of representatives across those three setting-specific committees in primer. Next slide, please. So MSR uses the cascade of meaningful measures, also referred to as the cascade, to identify measures for discussion in any given MSR cycle. The cascade of meaningful measures is based on the 8 healthcare priorities of Meaningful Measures 2.0, and it's a tool to help prioritize existing healthcare quality measures, to align or reduce measures where there may be too many, and to identify gaps where new measures may need to be developed. So the cascade is used to promote a cross-program lens of the CMS measure portfolio. We've broken the CMS measure portfolio into 3 cycles labeled A, B, and C, using the cascade priorities as a guide, and we aim to consider all measures in the CMS quality portfolio over the course of a 5-year period. Next slide, please. So this slide, there's a lot of information on the slide, but the goal here is really to convey our longer-term plan for MSR. Last year, or year one in the top row there, was a pilot year for our new processes. And we focused exclusively on measures in the end-stage renal disease quality improvement program. But after that pilot year, we made some improvements, took some feedback into account, and we are focusing on cross-program measure set reviews in the years that follow. So again, this year, we're focusing on the Cycle C measures, which address appropriate use in the financial and operational aspects of healthcare delivery. This cycle includes measures that are in the affordability and efficiency priority of the cascade of meaningful measures. Next year, in that year 3 row, we anticipate focusing on Cycle A, patient-centered and outcome-focused care. This group of measures focuses on individualized needs of patients, emphasizing personalized care plans, preventative measures, and chronic disease management. And so in year 3, we'll focus on the person-centered care and wellness and prevention priorities of the cascade that are in Cycle A. In year 4, we'll focus on the chronic conditions and behavioral health measures in Cycle A. Then in year 5, we'll turn to Cycle B, which is safety, quality, and equity in healthcare delivery. This group of measures focuses on creating a safe, equitable, and coordinated healthcare environment, and will consist of measures from the safety, seamless care coordination, and equity priorities of the cascade of meaningful measures. So that is our plan to cover measures in that 5-year period. Next slide, please. So just to reiterate where we are now, last year was the pilot year with a focus on a single CMS program. This year, we used the cascade of meaningful measures to focus on measures in Cycle C, which addresses appropriate use in the operational and financial aspects of healthcare delivery. Next slide. So what are we doing here today? The purpose of the MSR process is to optimize the CMS measure portfolio via review of measures for continued use in designated CMS quality programs. There are 4 major steps to the process that I'm going to briefly describe. So first, we identified the cycle focus. We did so with input from our committee members and from CMS. 35 measures were selected from the affordability and efficiency priority of the cascade based on a set of considerations that were vetted with input from committee members at the 2024 PQM Measure Strategies Summit in April. That list of 35 measures and the selection considerations was posted for public comment. At the next step, we developed the preliminary assessments, or the PAs, for each of the 35 measures. And these are measure summaries that compile information about the measures from various databases, including the CMS Measure Inventory Tool, the PQM STAR database, and we also include some analysis about measure performance and reliability. The preliminary assessments are developed with input from CMS leads and from measure stewards and developers, and we post those PAs for public comment as well. At the third step, the recommendation group members completed pre-meeting initial evaluation, or PI forms, using the preliminary assessments to evaluate measures based on the MSR evaluation assertions, which we'll talk about more in just a minute here. So these evaluations were collected in a Microsoft form and give us a sense of what committee members are thinking, and it also helps us prioritize areas of disagreement for this conversation we're going to have today. And the fourth step is what we're doing today. We're bringing the committee together to discuss feedback on the MSR measures, and we're going to develop consensus-based recommendations on whether measures should continue in CMS programs. And I'm now going to turn it over to Lydia Stewart-Arts, who's our evaluation lead, who will talk in greater depth about the MSR evaluation assertions, those preliminary assessments, and the PI forms. So Lydia, over to you.
Thank you, Meredith. And thank you for everyone joining this morning. I'm going to review our MSR evaluation criteria. For those of you who are committee members or representing CMS, you will have seen these slides before, so these will just be like a brief reminder as we prepare for our discussions today. Next slide, please. So the first criteria that we should consider is meaningfulness in the context of use. And so when evaluating meaningfulness, committee members should consider if the measure provides importance, validity, reliability, and usability. And there's some questions for you to consider for each of these aspects. So for importance, please consider, does data show us that using the measure in the chosen quality program will provide benefits that outweigh the costs? For validity, please consider, is it clear that a clinician or the measured entity can make changes to improve the desired outcome? For reliability, please reflect on whether the data shows us that differences in measure performance across clinicians or entities truly reflects differences in care quality. And for usability, please consider two things. First, is it clear that this measure can be effectively implemented and used? And then next, is it clear that any barriers to doing so are known and addressable? And I will also encourage committee members to use this evaluation criteria as meaningfulness as equal to the other two criteria that we will be reviewing today. I know conversations around scientific acceptability can be a little more familiar, especially for those of you who have taken part in the endorsement process or who are measure developers yourself. However, as Meredith describe, the overall goal of MSR is to optimize CMS measure portfolios. And so please consider meaningfulness criteria equal to the other two criteria today. Our goal today is not to have proxy endorsement discussions. Okay, next slide, please. The next criteria for you to consider is that of data stream parsimony. And when evaluating entity data stream parsimony, committee members should please consider, first, that the clinical data flow required for the measure promotes non-burdensome data collection and reporting. So examples of this might be a measure that utilizes data elements that are routinely captured during normal course of care in an electronic health record versus something that may require a specialized survey. Next, please consider that measure set redundancy in data streams is identified and mitigated. Okay, so this is the second criteria to consider, data stream parsimony. Next slide, please. And the final criteria to please consider today was that of the patient healthcare journey. So when evaluating a measure's alignment with the patient healthcare journey, please evaluate two things. First, whether the measure addresses the appropriate aspects of care to align with the patient healthcare journey. So this is getting at the kind of what and when of a measure. What are we measuring? When are we measuring it? And does that make sense with what we know about a patient's experience with whatever condition is being addressed by the measure? And then secondly, that the measure set is implemented across the patient healthcare journey in a manner consistent with the measure set impact model. For those of you on the call representing a patient or patient or caregiver perspective, I encourage you to be vocal about your experience, to share any experiences that you feel comfortable disclosing. I know in your pre-meeting evaluation or PI forms, we did receive some stories about personal experience and your perspective as a patient. If you feel comfortable disclosing those, I encourage you to bring them up to your fellow committee members so that they can have a better understanding of alignment with patient healthcare journey for those who maybe have not experienced various conditions that we're talking about today from that patient perspective. Next slide, please. Okay, so in order to prepare everyone for today's conversation, we provided committee members with preliminary assessments based on feedback we received last year. These preliminary assessments took kind of an at-a-glance or a snapshot format this year. It included descriptive information about measure specification, endorsement history, and current use. It also provided a CMS-provided rationale for measure inclusion in the CMS program. We gave considerations for any statutorily required measure areas or upcoming rulemaking that's planned. And when possible, we provided an analysis of the most recent past 3-year performance in the CMS program. Next slide, please. You guys use these preliminary assessments and your own personal experience to complete your pre-meeting initial evaluation or PI forms. For those of you who aren't sitting in the committee member seat, these PI forms were really straightforward. They use plain language for each of the 3 criteria that I just outlined, so meaningfulness, data stream parsimony, and patient health care journey. We asked the committee members to consider whether that measure met that criteria, yes or no, and then give kind of a free text response providing their rationale. Those committee member responses, we reviewed them, we synthesized the data, we gave, on subsequent slides, you will see a very high level aggregated summary of those responses, but I do encourage those committee members who gave very thoughtful kind of discussion about the measures. Your fellow committee members won't have seen your PI form responses, so please feel free to share some of those initial thoughts that you were gathering while completing those forms. Please share those during today's discussion so that we can make sure that everyone's concerns or enthusiasm for a measure is heard today. Okay, and with that, I will say next slide and hand it back over. Thank you.
Great. Thanks so much, Lydia. So I'm going to talk a little bit about voting. Next slide, please. So once we've concluded a discussion about each measure, the committee will vote to recommend a measure for continuation in a designated CMS program or not. As Battelle facilitators, Brenna, Rabel, and I will be working with Rosie and Akeen, our co-chairs, to keep the discussion on track and to ensure that all voices are heard and ensure that decisions are reached. We do use an online voting system called Voteer to capture votes by committee members. And in measure set review, consensus is a simple majority or greater than 50% of the committee members voting. Next slide, please. Voteer, again, is the online voting system that we use, and each committee member will have received an individualized voting link this morning, and will vote on each measure after concluding discussion. For measures that are used in multiple programs, there will be a separate vote for each program. And we'll actually do a test of Voteer in just a minute. But next slide first. Just for clarity on what we're voting on, a yes vote will indicate that the measure should be continued in the designated CMS quality program, and the no vote indicates that the measure should not be continued in the designated CMS quality program. Unlike primer, there is no option about conditions for measures in use. So during the discussion, we will likely provide a lot of useful feedback to CMS how measures can be improved. With that yes vote, you are saying that the measure should be continued either in its current state or with the improvements discussed. With the no vote, you're really saying that the measure cannot reasonably be improved, it does not have value, and that it should be discontinued. So again, there's no third option here, and reserve that no vote for when there's really no opportunity for improvement with the measure. Next slide, please. So there are actually two types of quorum that we need to achieve today and that we'll be tracking throughout the day. First, we have discussion quorum that requires attendance of at least 60% of the active recommendation group members to be present at roll call. And second, the voting quorum requires at least 80% of active members who have not been recused to submit a vote. So what does that mean for you as a committee member? Next slide, please. It means that it is extremely important to the process to have voting quorum, and we really kindly request you to stay on for the entirety of the discussion and voting. We do have a couple of breaks built in, but if you do need to step away for a few minutes, we ask that you please make a note in the chat when you depart and return. And if we do happen to lose voting quorum or discussion quorum, we will need to move to asynchronous voting to follow up with absent committee members. Next slide, please. So to summarize our quorum requirements based on our active members only, not yet taking into account measure-specific recusals, we need 15 committee members to have a discussion and 20 members to vote. Again, greater than 50% of votes represents a consensus. And actually, before we move into the voting test, I wonder if, Kate, did you want to check back in on COIs for some members that have joined us since we started?
Yes, thank you. So so first of all, Christine, thank you so much. I did note you said you didn't see a voting link in your email, so Isaac can get you hooked up on that. But Christine Ron Raisville, would you mind introducing yourself and saying if you have any disclosures?
Sure. Christine Van Raesveld here. No disclosures. So I sent in the form and hopefully I'm all set. Thanks.
Thank you. And then we had Nishant, but he, I think, dropped again. So we have, if I am counting correctly, and I believe I am, we have 23 of our 25 active committee members here right now.
Perfect. Thank you. So now I think we're going to move to the voting test, so we can move to the next slide. And I'm going to turn it over to my colleague, Isaac Seichi, to walk us through the voting test.
Thank you, Meredith. Good morning. My name is Isaac, and I'll be walking us through today's voting. Around 9 a.m. Eastern, you should have received an email containing the voting link. So please look for an email from noreply@votier.com. And the subject of the email contains the phrase voting link. So please take a moment to locate that email. And if you can't find it, that's okay. But let us know and we will send the link to you via email. And as a reminder, this link is only for the MSR recommendation group members. So we ask you to refrain from sharing the link in the chat. If at any point you encounter challenges with the voting platform, you can send your vote directly to me in the chat. With that covered, we can go ahead and test the voting platform.
And just a reminder, as folks are locating that email, check the spam filter or clutter folder just to make sure it didn't end up in there.
Thanks, Meredith. So today's question is whether or not you think a hot dog is a sandwich. So the options are A, yes, and B, no. And again, we're expecting 23 votes. We have 13 votes in so far.
And Isaac, would you mind resending David and Christine's voting link? They said they couldn't find it.
Yes, we will
I
send.
actually found mine, so
Oh.
you should have received my vote.
Okay.
I cannot find it in my spam or folder, but we have a double level, so it could be in the one that doesn't release till later today.
Okay, David, we will send it to you shortly.
Great, thank you.
And it says mine has timed out.
Oh,
Good.
please send to David Seidenworm at my Gmail. Thank you.
Okay, we will send that to you. If your screen timed out, please try refreshing your page. And if that doesn't work, try using a different browser. So far we have 20 votes.
Am I supposed to put a different voter ID in or the one that came with my link?
Once you click on the link, it should take you directly to the question that is currently being presented.
Nope, it doesn't. It has a voter ID, and then it's when I click join, it says your session has expired. You will be redirected to the login page.
Jennifer, you should have received a different link. So there is another link I sent to you specifically. It has voting link 2 in that email.
I'll check my spam filter again. That just keeps going in there.
This is an important question. I can't believe they're going to spam.
We have 22 votes, so just waiting for Jennifer's vote.
Isaac, I see that Corinne Rubin has joined, so we should expect 24 votes. Also, Corinne, would you mind verbally disclosing any conflicts of interest?
Hi, this is Corinne Rubin from the American Medical Association. I don't have any conflicts. Thank you.
This is David Levine. I still haven't received, I might be the one outlier vote. I still haven't received anything. I put my personal email in the chat as well. That might work.
Okay. Corinne, we have your vote. Thank you.
So Isaac, are we waiting? So David doesn't have his link. Are we waiting for anyone else?
We're waiting for.
I was able to find the link in my other email. Thank you.
So we have 23 and David Levine's vote. We're still waiting for that.
My link just came through, so I'm working on voting. Now I just have to work on the hard question. Okay, my vote should be in.
All right.
Jennifer said that hers worked for her. Thank you, Jennifer.
Yeah, we have all 24 votes.
Okay, great.
Okay, with voting closed on the very important question on whether or not a hot dog is a sandwich, we have 33.33% voting yes and 66.67% voting no. So I guess it is not a sandwich.
There you have it. Okay. So Isaac, is there anything else you needed to cover?
That should be it. And just another reminder, as we proceed with today's meeting, if you're having any issues with sending in your vote via the Votier platform, please send your vote directly to me in the chat if you're unable to send it via Votier.
Okay. Thank you. Thank you, Isaac, and thanks to everyone for working through that test with us. So we're about about ready to kick things off with our measure review. Just a couple of things I wanted to mention before we get into the measure specific information today. So next slide, please. I just want to sort of review the flow that we're going to follow for each measure. It's going to be the same pretty much across every measure we discussed today. I just want to review that kind of up top. So there is a summary measure information slide that Battelle facilitators, either Brenner or myself, will review. And then we will pass it over to a CMS medical officer to provide a brief measure overview or contextual background on the measure. Then it will come back to the Battelle facilitator to review public comment, summaries, and PI results. And then we'll turn it to the committee to discuss, and then we'll vote. And so again, that order is going to repeat over and over again. And before I move on to the next slide, just a reminder, if you are joining this call as a developer or measure steward, please do rename your display name so that it says first name, last name, and your organization name, similar to what you'll see for me, Meredith Eastman at Battelle, so that we can promote you to panelists when it's time to discuss your measure. Next slide, please. A couple of global overarching comments that we wanted to share today before we dig into the measure-specific reviews. We wanted to make everyone aware of some work that our colleagues at the Institute for Healthcare Improvement, or IHI, did to assess the health equity implications of measure continuation or discontinuation for the measures that we'll discuss today. I did want to note that equity is not one of our MSR evaluation criteria or assertions. However, the health equity assessments that IHI conducted do support the committee's efforts to provide meaningful feedback to CMS and measure developers on this topic. For all measures that IHI reviewed, they identified stratified reporting. This could be by race, by ethnicity, ancestry, language, sexual orientation, gender identity, social determinants of health, and other relevant demographics as a strategy that CMS could use to enhance health equity via quality measurement. So this is just a recommendation for CMS consideration, but it should not factor into committee decisions or your voting. Next slide, please. As we go through each measure, you'll see a summary slide that contains summary of public comments that are relevant to each specific measure. But we did want to also summarize some overarching themes across the two public comment periods that we had. First on the MSR list of measures, and second on the MSR preliminary assessments. And you can see we got a total of 29 comments across those two time points, with the majority coming in as response to the list of measures. So again, we'll review these measure-specific comments in context, but emerging themes included the need to prioritize patient safety while balancing cost efficiency, the importance of retaining evidence-based measures that prevent overuse and unnecessary procedures. There was concern about administrative burden and calls for better alignment across programs, and there were calls for actionable patient-specific data to drive healthcare improvements. And lastly, there was concern about lack of meaningful performance improvements on measures. So we can move on to the next slide. And we will get started on our measure-specific reviews. So the first measure we're going to discuss today is a measure used in the MIPS program. It is adult sinusitis, antibiotic prescribed for acute viral sinusitis. It is an overuse measure. And you can move to the next slide. And I'm just going to provide a brief overview of some basic measure information on this slide. This measure is the percentage of patients aged 18 years and older with a diagnosis of acute viral sinusitis who are prescribed an antibiotic within 10 days after onset of symptoms. The measure steward is the American Academy of Otolaryngology Head and Neck Surgery Foundation. And again, this is a MIPS measure. It's a process measure. The level of analysis is the clinician. It is not endorsed and has not been endorsed. All data are required. All data that are needed for this measure are collected as part of the clinical workflow, and it is not in a statutorily required category. So now I'm going to turn it over to Ron Klein for some contextual information on this measure.
Good morning, everyone. My name is Ron Klein. I'm the Chief Medical Officer for the Quality Measurement and Value-Based Incentives Group within CCSQ. I have the pleasure of leading off with the very first measure. And I will introduce the measure, but it's going to be important for me to point out for this and for other measures that we have our QuimVig program leads and measure leads who are on the call. So if we really want to get into the weeds, we have the ability to do that. So this is the adult sinusitis, the antibiotic prescribed for acute viral sinusitis measure, which, as was mentioned, is an overuse measure. CMS recommends maintaining this inverse measure of appropriate use to avoid antibiotic overprescribing in patients with viral sinusitis. Reducing antibiotic overuse is a high priority for CMS. The measure aligns with clinical guidelines from AAO and HNS sinusitis guideline from 2015, and is clinically applicable to many clinicians. Due to the measure's broad applicability, it is included in 6 specialty sets and 2 MIPS value pathways. It is in adopting best practice and promoting patient safety within emergency medicine, MVP, and the quality care for the treatment of ear, nose, and throat disorders, MVP. It has a 2024 historical benchmark of 23.32%, indicating there's still a gap in performance. And historical benchmark data for this measure demonstrates overall improvement in performance from year to year, indicating that the measure is doing what it is supposed to do, which is to drive clinical quality improvement. In the calendar year 2025 physician's fee schedule proposed rule, we propose a substantive update to the instructions for this measure for clarification of what constitutes an occurrence for purposes of attributing patients to the denominator. For the aforementioned reasons, we would recommend maintaining this measure in MIPS. And with that, I'll open the discussion.
Thank you so much. And we're actually going to move to the next slide, and I will review what we received in terms of PI form feedback and public comment. So we had 4 committee members completing their pre-meeting initial evaluation forms on this measure. 3 said that this measure met the meaningfulness criterion, the patient journey criterion, and the data stream parsimony criterion. 1 individual said that these criteria were not met. So you can see a summary of that discussion here on the left. We did receive 2 public comments in support of this measure, with 2 arguments being provided by the measure developer. And those are summarized on the right side of your screen. So I think we can sort of turn to the committee discussion. On the next slide, we have just a couple of questions that you might be interested in responding to get us started. Please feel free to speak to these questions or bring up your own points for discussion. But a couple of things to consider. In the preliminary assessment for this measure, we showed little to no opportunity for improvement for the top 60% of reporting entities. And so how can this measure be used to improve quality for those lower performers? And then there was a suggestion from 1 committee member to extend the denominator population to include individuals under 18 years of age. So that's something to consider as well. So I will open it up to the committee. Corinne, yes.
Hi, Corinne Rubin from AMA. We also would support maintaining the measure in the program. I'm concerned removal from the MIPS program would, I know there's a limited number of measures that are applicable for ENTs, otolaryngologists. And so I think that is also something when it comes to the MIPS measures that needs to be taken into consideration. So I think the framing for the MIPS measures needs to also look at the requirements of MIPS, and physicians are required to report on 6 measures to successfully participate in the program. And so for many specialists, particularly surgical related specialties, they are challenged with finding 6 relevant, meaningful measures.
Thank you for that, Corinne. And I see, Christine, you have your hand up.
Yeah, I just wanted to make a comment on the opening it up to individuals under 18 years of age. And as a patient who has gone through multiple, kind of infections growing up, I think it's important to start early on that. So I would back up the including individuals under the age of 18, just seeing that it is an antibiotic, overused antibiotic.
Thank you for that. And Rosie, I think you have your hand up.
Yeah, and I guess I agree with Christine because also in the long run, adults that end up overusing antibiotics usually have started at a young age with their parents, getting them antibiotics so they can go to daycare or they can go to school or they can go any certain places and this is a viral sinusitis and we know viral antibiotics are not very useful for viral, but yet, parents often that's the requirement for their schools or their daycares is if they're on an antibiotic and they're fever free, then they can come back to school. And so that's, I think lowering that age would be helpful. And that might be the area where we can see some improvement.
Thank you for that, Rosie. And Amy, you have your hand up.
Yeah, I was actually one of the folks that had this for a measure for review, and I don't think we've capped performance. So I still think there's opportunity in this measure. And just to echo what my colleagues have said, we really need to continue to push appropriate use of antibiotics.
Great. Actually, Devika, before I call on you, I wanted to see, I think we've had Nishant Anand join. Nishant, if you wouldn't mind saying hello and letting us know if you have any conflicts of interest to disclose.
Hi, Meredith. I have joined. I'm Nishant Anand, and I'm the CEO of Alteas, and I have no conflicts to disclose.
Super. Thank you. So, Devika.
Thanks. I think I might have been the committee member who was interested in extending the denominator to individuals under 18 years of age. Wasn't sure if that was feasible, but because of what my colleagues on this panel have said, I do think that increasing appropriate antibiotic prescription is one of the most important things that we can focus on in healthcare. I'm speaking as a clinician and a health services researcher, not representing any particular organization. So if that is possible, I think it would have major impact. I don't know if we're discussing kind of other aspects of this measure, but one thing I was curious about is how the kind of 10-day window period was selected.
Yeah, I wonder if CMS could speak to that 10-day window to provide a little insight there.
This is Lisa Marie Gomez with CMS, and we have the measure steward on the line. So Janelle, would you like to address that particular question?
Sure. So I'm Janelle from the American Academy of Otolaryngology, and how we based the 10-day timeframe was based on the current CPG that was released. We actually have an update coming up in the spring of 2025. I can't obviously discuss what's going to be in it, but we are going to be updating some aspects of this measure, and that's why we also recommend obviously maintaining the measure to keep with the compliance of the updated CPG.
Thanks, Janelle.
Thank you. David, you have your hand up.
Yeah, I'm supportive of the measure, but I was just curious about the one member objection as far as, around burden or delay in treatment. I was trying to understand if there was anything that we were like missing, and I didn't read the complete measure, but is it something that if you're coding viral, I'm totally supportive of it. Is it something that comes back if the swab comes back later and it's viral, but you're treating presumptive bacterial? Do you get tagged on this?
I think that's a specification clarification for CMS, if you wouldn't mind.
So could you repeat the question? Because I want to make sure if it's questions for me or for the steward.
Yeah, I just wanted like the requirement to diagnose it as viral sinusitis. Is it based on a lab finding, or is it based on just a presumptive diagnosis of the physician?
I'll actually defer to the steward. Janelle, would you be able to address that question?
Yep. Hi, David. To answer your question, we actually do base it on coding. We have ICD-10 codes listed in the measure spec, including several J codes, but we also do look at wording free text that physicians may use in their notes, and that includes like purulent nasal drainage, cloudy color, any type of facial pain, pressure, fullness. So we do look at both aspects, keywords and coding.
Yeah, I guess my only potential concern is if I'm treating a patient, if I see a patient and based on clinically, I'm very convinced that it's not viral, that it's bacterial. So I treat later, the swab comes back negative with a viral. Does that change the coding? And then like I, as a clinician, am tagged?
If the coding does change, our system will, or like how we abstract will pick it up. So it will count as the acute viral sinusitis. If your initial visit didn't show that, but you guys updated in the system, it will pick it up and add it to the denominator if it comes back later as this viral.
Okay, thank you.
Okay. Great, good clarification. Any other committee members have thoughts on this measure, either in support of continuation or vice versa? So just to kind of summarize what I've heard thus far. Oh, David, your hand is still up. Is that a relic from an earlier time? Oh, there you go. Okay. And Rachel Blair, you have your hand up.
Hi, this was one of my measures actually, and when I was looking at it, I was thinking with the theme of like cost effectiveness and stuff like that to go with the group. And this measure does really help improve cost effectiveness, because then if we're not overprescribing, then we're avoiding that antibiotic resistance. We're not having super bugs that we have to treat. So this measure absolutely works in line with, the theme of cost effectiveness and making sure that the measures fit into that little niche. That's all.
Yeah, thank you for that. And I'm just kind of taking a look across the PI forms. There was a concern raised, I think Nishant Anand, just not to put you on the spot, but I think you raised a concern about the specificity of diagnostic tests for this, and the limitations of identifying viral versus bacterial sinusitis. I don't know if you wanted to add reflection on that point.
No, very similar to what David brought up. So I think he answered. I was thinking very similar to that. But generally speaking, if the clinical diagnosis is going to be viral sinusitis, there's very little to no room for antibiotics unless you're trying to prevent a superinfection. So I think David answered that. Meredith, can I ask a question on the second part? So if we extend, as a committee recommend, extending the denominator population to people under 18, which I support, is that something the measured steward would go back just as a matter of process and then resubmit? Or what would be the next step if we are extending it, or recommending, I guess, extending it under 18 years of age?
Hi, this is Lisa Marie with CMS. So anytime that there's like an update to, let's say, a measure, we look at measures on an annual basis, but any updates that we have to a measure goes through the rulemaking process. So for example, if let's say there was a change that wants to be implemented, let's say for 2025, those would have had to have been in our proposed rule, which was published in July of this year. So any other changes to a measure would have to be implemented in 2026. So if let's say the recommendation would be to expand the denominator population, specifically relating to the age of patients, we would work with the steward and look at those dynamics and potentially include that in the 2026 proposed rule. But also I want to note that any particular changes to a measure, depending on like the types of changes, we look at, like I said, different dynamics and work with the steward. So it's not always guaranteed that something will happen immediately, but it's something that we can also always consider in updating the measure. And working, and again, it's in particular in working with the measure steward.
Thank you.
Marianne, you have your hand up.
Yeah, just in terms of the recommendation to expand the denominator, isn't there a separate measure already for the pediatric population? And I'm assuming, I mean, this is for the Medicare program, so we're dealing with, 65 and up generally population. So I think too, we'd have to be cautious with expanding the denominator for pediatrics because you're going to get differences in the population, and it would impact how scoring is and whether it's really appropriate to include the pediatric population here and whether it's better suited to just have a separate measure to address the issue.
Hi, this is Lisa Marie with CMS. I just want to note that under MIPS, our measures are all payers, so it not only includes Medicare beneficiaries, but all payers. I will note that there are other measures in MIPS that do include pediatric populations, so our measures are not specifically limited to that. Specific, we'll be looking at Medicare beneficiary age range.
Thank you for that clarification. And I did just see a comment from Stephanie Ledbetter in the chat. Stephanie, you're agreeing with Corinne's point about being cautious when expanding to pediatrics. Did you have anything you wanted to expand on there?
No, I not really. I just think it's very prudent that we're careful with that. When I first saw the measure, that was my thought, and then also related to the measurement of the 10-day window. Those were my two thoughts.
Okay, great. Thank you. David Seidenworm, your hand is up.
Yeah, just on the topic of expanding to the pediatric age group, we would have to have some data on the relative performance in the different age categories and perhaps consider some sort of severity adjustment or stratification approach there. And I'm sure that that will come up as this is considered over the following year if we adopt that type of recommendation. But just I think we should in general be a little bit cautious about our recommendations and understand that they're just sort of things to be considered and advisory because the process of measure development can be complex and something that may seem like a good idea to us, right now in an ad hoc fashion may not really stand the test of scrutiny.
Oh, that is a great point.
And also, if I may ask Janelle to outline maybe the reasons why the measure was structured with the age range that it is currently structured at, just to give context so that everyone here understands, where the steward was coming from in terms of developing the measure and developing the denominator population. Janelle, I don't know if you want to be able to expand on that.
Sure. I mean, it's similar to what I was echoing before, or I was just echoing what I said before, where this measure was based off of the clinical practice guideline of sinusitis that was released, and that's where we were pulling the age range and the 10-day window. But like I said before, we have an update coming in spring of 2025 to the clinical practice guideline for sinusitis. So,
thank you.
Great, thanks. Christine asked in the chat if there are any mechanisms in place to gather ongoing feedback from clinicians and patients about this measure. So I think that's a question for the steward as well.
So this
I'm
is
sorry.
Lisa Maria CMS, but I can at least address the CMS part, and then you can also address the
Sure.
the CA component. So one thing that there's different means. So anyone can always reach out to the steward to discuss potential changes or things that they would like to do with regards to the measure. But also we include, if let's say, for example, we're proposing changes to a measure during the rulemaking process, there's always a formal process for submitting a comment relating to a measure. On an annual basis, we review measures to determine if there are updates or if we're removing or adding measures. So every year during the physician fee schedule rulemaking process, there's always that opportunity. And Janelle, I'll extend it to you.
Nope, you kind of just said everything I was about to say, Lisa Marie. So it's just we're constantly getting feedback throughout the year. So when it does come time for the self-nomination, we research the the recommendations from our ENT physicians and see if they're possible or if it does improve the measure and the numbers, and then we submit it for self-nomination. So we are constantly looking for feedback from our physicians.
Thank you for that. I think we've heard largely comments in support of continuing this measure. Did any committee members want to disagree with that or voice concerns about continuing this measure? Okay, so what we've heard so far is just concern that if this measure were to be discontinued, that there would not be enough options for otolaryngologists as a specialty to select in MIPS MVPs. So those requirements should be considered. There was support from a number of folks about potentially expanding the denominator population to include patients under 18. However, there were also expressions of caution for that recommendation, noting that the measure developers and stewards may find, in testing that is not a viable option, or potentially the need to stratify or make adjustments for differences in age groups. We also heard that this is an appropriate measure to consider in terms of cost effectiveness because it promotes the appropriate use of antibiotics. Superbugs are costly and are to be avoided. So that was one voice in support of continuation. And let me ask Rosie and Akeen, did I miss anything in that summary that you heard?
I think you covered everything from the patient's perspective in the summary.
Yep, sounds good.
Okay, so I think, are we ready to move to a vote, Rosie and Akeen?
I'm ready.
All right, so Isaac, that means you are up.
All right, the question should be showing up on your screen shortly. Voting is now open for the measure on adult sinusitis, antibiotic prescribed for acute viral sinusitis, overuse. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, B, no, discontinue use. Please make your selection, click vote, and then click on finish. And we are expecting 24 votes. Waiting for 3 more votes. Waiting for 2 more.
I'm having difficulty voting. You can score me as a yes. Please, this is David Seidenwer. I'm sorry for the technical difficulty.
Thank you, David. In the future, would you mind sending your vote directly to me in the chat? We're waiting for 1 additional vote. Nishant, are you able to send in your vote?
It looks like Nishan stepped away, Isaac, so it's 23 votes that we're expecting.
Okay. Voting is now closed. We have 23 votes for A and 0 for B, with 22 votes at 100% voting to continue use of the measure. The committee recommends the continued use of the measure in MIPS.
Okay, great. I think we can move to our next measure discussion. And just a reminder, if you do step away, please let us know either in the chat or by messaging the host that you are stepping away. If you do step away, we risk losing quorum, and we don't want to do that. So please do try to hang in there with us, or at least keep us posted on your participation as we move throughout the day. So the next measure is age-appropriate screening colonoscopy. This is another MIPS measure, and we can move to the next slide with the measure overview. So this is an overuse measure that captures the percentage of screening colonoscopies performed in patients greater or equal to 86 years of age from January 1st to December 31st. The measure steward is the American Gastroenterological Association, and again, this is a MIPS measure. It is a process measure. The level of analysis is the clinician. It is not endorsed and has never been endorsed, and all required data are collected as part of the clinical workflow for this measure, and it is not in a statutorily required category. So with that overview, I will turn it over to Marcia Smith at CMS to provide some additional context.
Hi, I'm Marcia Smith. I'm a medical officer in the Quality Measurement and Value-Based Incentives Group. And the age-appropriate screening colonoscopy measure assesses the overuse of screening colonoscopy performed on individuals aged 86 and older during the calendar year. This measure aims to ensure that screening colonoscopy is performed appropriately, considering the patient's age, risk, and complications that may occur in older patients. Through the federal rulemaking process, CMS is proposing the removal of this inverse measure from MIPS due to the quality action being measured having become standard of care based on MIPS performance data, in which the measure had limited opportunity to improve clinical outcomes. Performance on this measure is extremely high and unvarying, making this measure extremely topped out, with the 2024 historical benchmark showing a performance rate of 0.15%. We understand that as part of the MSR process, there were public comments indicating that the removal of this measure would impact the QCDR, which is a Qualified Clinical Data Registry measure set that includes this measure. We note that there are some MIPS quality measures that are the same as QCDR measures. However, the removal of a quality measure from the MIPS quality measure inventory does not impact QCDR measures. The proposal to remove the measure would be a removal of the measure from the MIPS quality measure inventory. QCDR measure inventories are not considered when assessing MIPS quality measures inventory, as it would be incumbent upon the QCDR to support their clients with their measure reporting. We understand that there was another comment indicating that the measure underwent substantial changes in 2022, in which the 2024 historical benchmark was based on performance data from 2022. The commenter indicated that 1 year of data would not be sufficient to determine whether or not the measure was extremely topped out. We note that prior to the measure undergoing these changes, the measure was already extremely topped out. Based on this analysis, CMS has determined that the inclusion of the measure in MIPS for 1 to 2 more additional years would not change the status of the measure from being topped out. Once the measure has reached the extremely topped out status, CMS may propose the measure for removal in the next rulemaking cycle. During the extremely because of the extremely high and unvarying measure performance. Based on these factors, CMS has proposed the removal of this measure from the program in the calendar year 2025 year. Calendar 2025 physician fee schedule. That's all I have there. Thank you.
Great, thank you. So moving on to the next slide, we'll see our summary of pre-meeting initial evaluation form feedback, and as well as the public comment that Dr. Smith also provided an overview of. So in terms of the PI form feedback, split on meaningfulness, it was noted that this measure does prevent potential harms to older patients. Concerns expressed that it may not be as necessary, meaningful as in prior years because it is topped out. There was a consideration raised about revising the specification to lower the age to 83 and older instead of 86 and older. In terms of the patient journey, 3 committee members said that this criterion was met and 1 said it was not met. Patient journey comments indicated that this measure would limit patient exposure to a potentially harmful procedure, reduces costs and negative outcomes for patients. And again, there was concern about the risks for older patients and that this measure is measuring something that is, become the standard of care. In terms of data stream parsimony, 4 members, all 4 committee members who commented on this criterion, on this measure, said that, data stream parsimony was not a concern for this measure, that the measure does use data elements that are routinely available. In terms of public comment, we received 4 total public comments. 3 were supportive of continuation and 1 concern. I will note that we see among these comments of support were a comment from the measure developer and also from one of our committee members supporting continuation of this measure, and that the concern raised in public comment was that the relevance of this measure for patients over 85 years old is questionable because the proportion of these patients receiving colonoscopies is very small. So with that, I'll open it up for committee discussion. We have a couple of starting points on the next slide that we can move to. Again, calling attention to the small impact of this measure with the small proportion of patients 86 and older receiving colonoscopies. Preliminary assessments showing, and as Dr. Smith noted, this measure is topped out. And just a consideration about continuation. Is there a reason to believe that there are clinicians that serve certain communities that might be struggling with this measure? So what does the committee think of this measure? Corinne, yes.
Yeah, we're supportive of maintaining the measure in the program. We are looking at a vulnerable population, and the goal is to ensure that inappropriate screening for colonoscopies are not occurring. And the measure assesses whether eligible clinicians routinely perform screening colonoscopy, including those doing lower volumes, to determine if unnecessary screening of the elderly is being performed. So I think eliminate it, just because might be seeing some topped out rates, this is an important measure. And until we have like a replacement measure, I believe it's premature to be removed from the program and should be continued and available for clinicians participating in MIPS, given the focus on a vulnerable population, and it addresses overuse, therefore improving cost and resource efficiency. But also when it comes coming from an equity perspective, there is evidence out there that screening rates do vary based on that there are differences between white and Black populations. So that is also something that should be considered.
Thank you for that, Corinne. To other committee members, Devika, yes.
Is there a way to examine the topping out data if the upper limit of age were lowered? Would we still find, if we looked at that data, that the measure was still topping out?
So that would be a question for the CMS lead and potentially the measure steward.
Could you repeat the question about being topped out?
Yeah, it seems that the measure has topped out because there is such a small proportion of adults who get screening colonoscopies who are 86 and older. Is there a way to determine if the measure would still show as being really topped out if we looked at an age that was lower than 86 but higher than 80?
It would be difficult. Well, we could have. Well, it's hard to assess if the measure is structured at a particular age range for us to make those determinations. But I will defer to the steward, David Gadzina, who could potentially outline if he's seen anything just generally with regard to a lower age range and potentially what the measure would look like.
Yeah, I mean, Dave Gadzina from AGA. I would have to rely on my colleagues at ASG and ACG who run the GI Quick program, which is the QCDR that contains this measure. They should have data, but I wouldn't be able to provide an answer in real time at this point.
Okay, fair enough. Thomas.
So I guess my comment would be there is always a burden to measurement and there is always a burden to reporting. And unless there's an opportunity for improvement associated with that burden, we shouldn't ask for measurement and reporting. So I agree with the recommendation that this be retired just on that basis, because it seems very clear there's not an opportunity for improvement. So we should focus measurement and reporting efforts elsewhere.
Thank you. Scott, you have your hand up.
Yeah, I agree with Thomas. My question is that age that was chosen, I believe it was 86, is that the recommendations by the societies, or are there any recommendations to lower that age? If it is that age, then I would definitely echo what Thomas says and said, we're doing really well in this. And there is a burden to collecting all this information, but I'd be curious what the society's recommendations are for age.
So I mean, for the measure, Stuart?
Yes, please.
Yeah, so the measures are based on the USPSTF recommendations, and that so basically no patient should receive a screening colonoscopy above the age of 86, just because of the unintended consequences that could occur, on the previous slide, whether or not it's dehydration, risk to anesthesia, and so forth. So the measure itself was meant to make sure that no provider is conducting a screening colonoscopy, which is different than a surveillance colonoscopy, where there may be some individual issues that warrant it, but it's specifically for screening rather than surveillance.
Thank you. Yeah, I just want to make sure over time that age recommendation didn't change.
Thank you for that.
And this is Lisa. Sorry, Meredith.
Oh, go ahead.
This is Lisa May. I also just want to note that, just in general, that it's difficult to know ahead of time whether the top-down nature of the measure is a consequence of program structure and a measure selection bias. However, population level epidemiological evidence might be suggested. So I just want to note that it's always hard to say exactly the nature of being the top-down measure dynamic just at this juncture.
Thank you for that note. Akeem.
Thanks. So this conversation about the measure being potentially topped out and balancing that with the concern about making sure that these specialists actually have enough measures to report, I think is a very real one. Maybe this is a question for CMS. Can you talk kind of at a high level about how you handle topped out measures programmatically in the context of the MIPS program? I know potentially taking measures out of the program is one approach, but isn't there also some alternative scoring that's applied? It'd be helpful to hear just a little bit about that.
So in MIPS, when we're looking at measures, like on an annual basis, we look at our measure inventory and we look at whether there's a new robust measure to replace a measure. We look at measures that are topped out. So for example, in this case, this measure is considered topped out, and when we're looking at being topped out, we see that there is little improvement for performance. There are instances in which, like for example, let's say in a specialty set, there may be only, let's say, 4 measures. We may keep that topped out measure in order to allow those specialists to be able to participate and report in the program. Because as Corinne noted during the last measure, for MIPS, we require a minimum of 6 measures to be reported. And so we're looking constantly to have enough measures for specialists or just clinicians to be able to report in the program. So in the case, like as I indicated, when there's limited measures, there are potential options for us to keep that measure in the program just so that there are enough measures to be reported, or at least a number of measures to be reported for a particular specialty set. And then I will note that in our proposed rule in the 2025 physician fee schedule proposed rule, we are looking at making potential modifications to our scoring with regard to topped out measures and for specific specialties. So in the final rule, we will make our ultimate potential determination for that policy. But right now we're just in the proposed rule phase. So I can't speak anything further on that.
Thank you for that overview, Lisa Marie. Rosie, I see you have your hand up.
Right. Well, first of all, this is a screening colonoscopy, so this is not somebody who has an issue with colons and has had problems with with previous colonoscopies, but this is a screening one where they haven't had issues. So I kind of agree with CMS where this is, definitely probably don't need to put patients through this. I'm not that age, but I'm almost 10 years away from that, and I'm thinking, yeah, I don't want to have a colonoscopy at that age anymore. Unless I had a problem before that. So I think that word screening is important to point out that this is not a colonoscopy, a follow-up colonoscopy because you had an issue.
Thank you for that, Rosie. And just wanted to call attention to a comment from Christine in the chat. Christine, I don't know if you want to expand, but you are mentioning the possibility of shifting this measure to explore non-invasive screening methods for elderly patients. Did you want to expand on that at all?
Not really anything I need to expand on. I would think that if we're looking at this, can we shift the measure, to explore some of those non-invasive ways to, for a colonoscopy.
Mm-hmm. But again, this is an overuse measure. I saw in the preliminary assessments, there's overlap with other measures that are for screening and surveillance. And so just again, to point out, this is screening, not specifically for the detection or colorectal cancer prevention, just to make that point clear.
Thank you. It wasn't my measure, so I'm kind of just going off the seat of my pants.
So I think we've heard from a lot of the committee. Has anyone Does anyone have any comments that they haven't had a chance to make on this measure? Okay, so I'll just summarize briefly what I've heard. We heard sort of support for the goal of preventing unnecessary screening of the elderly, that this is a vulnerable population and unnecessary screening leads to unnecessary costs and resource use. There is an equity component where screening rates do vary by race, ethnicity. There was a discussion about the potential of lowering the age range and whether or not that would affect the topped outedness of the measure. And I think that's something we can't really assess on the fly here during this conversation, but there was a consideration about changing that age, though noting that it is in line with the USP, the Preventative Task Force current guidelines. We did hear that that this measure is extremely topped out, and we heard from MIPS about what their options are for handling measures that appear to be topped out. We do know that this measure is currently in the proposed rule for removal. Rosie and Akeem, did I capture everything there?
Yes, except there is one more comment in the.
Oh, thank you.
Okay.
Thank you. So Jennifer, you are raising the concern about implications for rural providers. Did you want to expand on that?
Sure. Given both volume and the more limited access to specialty care that occurs in rural, naturally, and there's more limited scope of services, we often see that when a measure is removed, this is just a general comment about measures, not specifically about the colonoscopy one, but in response to Lisa Marie's comments from CMS, when a measure is topped out, it's often topped out in urban and suburban care and not as much in rural. There are still either gaps or it removes a measure that still has relevance for rural. And so it narrows the rural relevant measure set, making it harder for being transparent in public reporting and making it harder for rural facilities to participate in value-based payment and other programs. So just a caution or an encouragement to be attentive to the rural implications of removing measures that are seemingly topped out.
Thank you for raising that issue. And I think that's something, as you said, it's a more of an overarching comment, something that we could return to throughout our discussions today. So thank you for raising that. Okay, are we ready to move to a vote, Akeem and Rosie?
I think we're ready. Akeem, what do you think?
I do too.
Okay, Isaac, over to you.
All right, the question will be showing up shortly. Voting is now open for the measure on age-appropriate screening colonoscopy. Do you recommend the continued use of this measure in the MIPS program? The options are A, yes, continue use, B, no, discontinue use. And we are expecting 23 votes. We're waiting for 3 more votes.
I texted you my vote, David Simon.
Thank you, David. I have your vote. All right, we have all 23 votes. Voting is now closed. We have 7 votes for yes, continue use, and 16 votes for no, discontinue use. With 72.73% voting for no, discontinue use, the committee recommends discontinuing the measures used in the MIPS program.
Okay, thank you, Isaac, and thank you everyone for your discussion and vote. I think we can move on to the next measure. Great. So I think there's going to be a little bit of commonality. Some themes that were touched on in the last measure may be relevant for this measure as well. This is appropriate use of DXA scans in women under 65 years who do not meet the risk factor profile for osteoporotic fracture. And this is a MIPS measure. So move on to the next slide, please. So just to provide some basic overview information on this measure is the percentage of female patients 50 to 64 years of age without select risk factors for osteoporotic fracture who received an order for a dual energy X-ray absorptiometry scan or DXA scan during the measurement period. This is a process measure. The level of analysis is clinician, and this measure is currently endorsed. All required data for this measure are collected as part of the clinical workflow, and it is not in a statutorily required category. So with that overview, I will now turn it to Lenice Cummings-Vaughn at CMS for some additional contextual information.
Good morning. My name is Lenice Cummings-Vaughn. I am a medical officer with QuimVig, specifically with Division of Chronic and Post-Acute Care. So the next two measures generally are overuse MIPS quality measures. Overusing methods of evaluation can lead to increased false positive results. Overuse comes from lack of evidence-based risk factors for high pretest probability that will qualify a patient for the imaging. The results of this inappropriate test can lead to further costly evaluation, exposure to unnecessary radiation, and unnecessary stress for patients. The window for provider performance change includes familiarity and use of evidence-based criteria for the imaging in the context of their patient. Now, specifically with the DXA or DEXA scan in women under 65, in the calendar year 2025 physician fee schedule proposed rule, we propose to remove this inverse measure from MIPS, including the removal from the Focusing on Women's Health MIPS Value Pathway, MVP, given that the quality action being measured has become standard of care based on MIPS performance data. The measure has a limited opportunity to improve clinical outcomes. Performance on this measure is high and unvarying, making this inverse measure extremely topped out, with the 2024 historical benchmark showing a performance rate of 1.1%, which is an extremely topped out measure with the average performance within 0 to 2% range for inverse analytics. Thank you.
Thank you for that background information. Let's move on to the next slide for the summary of PI feedback and public comment. So for meaningfulness, we had 2 committee members say that this measure met the criterion and 2 said it did not meet. In terms of supported comments, reviewers noted the importance of this measure in terms of preventing unnecessary radiation exposure, psychological stress, and usability in this setting. There were concerns expressed over the topped-out nature of the data presented in the preliminary assessment, suggesting minimal potential for impact or value added to care. In terms of the patient journey, there was support for this criterion, with 4 individuals noting that this was an appropriate measure for the care setting, and it is of value to patients. And in terms of data stream parsimony, we had 2 individuals saying that this criterion was met and 2 not met. Again, that was noted that the data elements are routinely collected as part of care, but the measure does not reduce redundancy. In terms of public comment, we received 1 public comment summarized on the right of this slide here. The public comment noted that harms from overuse from DEXA scans are relatively low, that the measure does not fill a significant performance gap, and that the denominator exclusion criteria do not follow current guidelines. So we can move to the next slide. So just a couple of thoughts to kick off the discussion. Does the committee agree that the performance on this measure is high and unvarying, suggesting that it's topped out? And are the risks associated with DEXA scans greater for certain populations? So potentially non-white patients or patients with co-occurring conditions that we should consider. So I'll open it up to our committee members. Christina, yes.
Good morning. So similar to our discussion on the previous measure, I do believe that this is a really topped out measure and doesn't bring much value.
Thank you for that. Any other thoughts? Jessica, yes.
I saw that there was a concern related to the exclusion criteria not meeting guidelines. Could someone share or review what the exclusion criteria for the measure are? In particular, as a nephrologist, I'm curious to know if chronic kidney disease is part of the exclusion criteria.
Let's see. Would the developer or steward be able to answer that question about whether chronic kidney disease is in the exclusion criteria?
Yeah, Meredith, this is Kate, just before we get into that. Some of our developers and stewards, in order to be able to talk, we have to promote you. So we're going to ask that you accept promotion. I know that we have one of the developers on. We're going to request the other one again to accept the promotion so that they can talk. Thank you.
Great, thank you.
Hello, this is Kelly Burleson. The end-stage renal disease is part of the exclusions for this measure.
Great, thank you for that. Does that answer your question, Jessica?
Just a follow-up. What about chronic non-dialysis kidney disease?
It is not part of the exclusions.
Okay. Did you have any follow-ups from that, Jessica? No?
No, thank you.
Okay. Corinne, you have your hand up.
Yeah, also just I remember looking at this measure a while back. I remember the reporting rates on this are pretty low. So are we really looking at like an accurate snapshot of this care? And I think that something just in general, as we consider topped out, that we should be looking at the reporting rates in conjunction to the applicable kind of specialty population, because sometimes it's pretty kind of subjective in terms of what the numbers are, and then in terms of the larger impact it's having or not having. So it's superficial to be making certain statements about care, standard of care.
Thank you for that point. I'm wondering if any of our patients wanted to add any comment. We did have, I think, unanimous support for this measure in terms of meeting the patient care journey criterion. So Rosie, I see your hand is up.
Well, as I look at this from a patient journey standpoint, this is pretty standard care, and basically, women, are asked to get this, have this done at a certain age, and so it's part of the care journey already, and so I think that's why many times it's topped out, or because it is part of the care journey. So I look at it as being standard care, and you know, I look at it even from the rural point of view, because I live in a rural community, and yes, I have to travel to a larger city to get this scan, but I also have had it because I'm over the age of 65. So.
Thank you for that perspective. And Christine, did you want to add?
I just wanted to ask Rosie, and I know that, do you think though that your age and everything that you get these scans more because you have had issues in the past? Because I'm not 65, I've had the scans just because of my conditions, but do you think like a normal person would have that access as well?
I think so, yes, because I have a daughter who has some issues too, and she's had the scan at a younger age because of having some issues with arthritis and rheumatoid arthritis. But
I'm just wondering because I'm in an area, different area.
I just feel that this is more accessible to the patient care journey than some other things are, some other.
Definitely.
Yeah.
Okay, I agree with you totally. I just wanted to kind of clarify in my head.
And especially my daughter also lives in a rural community and not, very close to me, and she's,
Yeah.
So.
Thank you for that conversation. Isis, I see you have your hand up.
Can anyone speak to subpopulations other than white women with higher conditions that we would need to consider? Other risk factors that we may need to consider?
I'm coming from the perspective of mixed race, just when we look at these things. So just as a thought.
Is the developer steward able to speak to any differences by race, ethnicity?
Kelly, I don't know if you're able to outline any of that information, because this is a CMS measure, but we have a developer on the line, so I don't know if Kelly can speak to some of those dynamics.
No, we're not able to speak to that at this time. That would be something we would have to look into.
Okay. Akeem.
This may actually build a little bit on the question that Isis just asked. As I look at the concept of being topped out here, I mean, I think the question that comes to mind for me is topped out for whom, and for what kinds of places. And the rural comment that Rosie was offering was kind of where I was going with that. Like, it would be one thing if we know that the performance is high and unvarying pretty consistently across geographies and across subpopulations. But if there are still some disparities here that we're not seeing, that would potentially argue in favor of keeping a measure like this one. I am very sympathetic to the arguments around measures being topped out. I'm a believer that as you get higher and higher performance, the utility of keeping something around goes down significantly. But if there's a gap there that we're not seeing, it would be helpful to know.
Thank you for raising that question.
I just wanted to note that, so with regard to NIPS measures, we don't require any specific measure to be reported. There's a flexibility for a clinician or a group or a virtual group or APM entity to select the measure that they choose to report. So we can't necessarily determine uptake of a measure just due to the fact that we don't require any specific measures to be reported in NIPS. So to determine if there's geographical differences in rural versus say urban areas, again, it just depends on who chooses to report the measure.
Thanks, Lisa Marie. David, you have your hand up. David Levine first. Sorry.
Yeah,
David.
to Lisa Marie's comment, like I think that's sort of the one of the issues with MIPS in general is you pick and choose measures, and in general you pick from a set that you do well with. So actually, with that, almost getting rid of a top out measure, in my mind, forces you to address some of the harder measures. So I would support eliminating the top out measure, being sensitive to the fact that there potentially are populations that are missing this measure, but they're not being forced to address it anyway. So it's not serving that purpose of hitting those disparate populations, unfortunately, due to the nature of the reporting.
Thank you for that. David Seidenworm.
Yeah, so these comments on topped-out measures are really crucial because I think that the definition of topped-out measures that are used in these programs may need to be reconsidered to take into account the fact that what we're measuring is whether they're topped out among the providers who submit the measures voluntarily. So it's topped out among the very highest performers. So I think until we know that it's topped out among the whole population, I think that we might want to design the programs in such a way that they reward the top performers rather than submit them to a potential penalty for having an inadequate number of relevant measures. So I just would ask CMS to reconsider the definition and explore some of the phenomena that have been discussed.
Thank you. Rosie, you have your hand up.
Yeah, I guess, people that have developed vitamin D deficiencies because of head covers and so nuns, Muslims, people that wear head coverings, they sometimes have problems and might that they may not have been topped out. But I agree that this might improve measures when we remove the ones that are topped out. Not talking about this one in general, but the one about measures that they improve measures because they do get to choose which measures they want to report on. And when you report on the ones that you're doing the best at, this is one that you're doing well at, so you're gonna report that one and maybe not report another one. But I guess the one that so people who cover their heads, because that often leads to vitamin D deficiencies, that is might be one area of concern. So because I have a vitamin D deficiency because I was a nun at one point in my life, and and then because of the infections, so I produce absolutely no vitamin D.
Thank you for that perspective, Rosie. Corinne, I see you put a note in the chat that you agree with what David Seidenworm was mentioning. Did you want to expand on that?
Yeah, I just want to highlight the scoring rules for MIPS and the high performance threshold to ensure that you don't receive a payment penalty, that even to just maintain a neutral score, are extremely challenging. And as a result, how the program is designed, you are either often forced to report on the measures that you're doing well on because there are no alternatives, or because you need to report on what you know in order to not get a ding to your reimbursement. And given that physicians haven't received an inflationary update and are operating in the negative, we are talking about an accountability program that impacts payment, and unfortunately can't disconnect that. And then also how the rules are for topped out measures, where you do get a reduction in the amount of points you're eligible to report on. The intent of that was to force physicians to report on new measures, but as a result of limited measure availability in MIPS, that hasn't happened in practice. And often, even if you're reporting on the topped out measure, you're still struggling to meet the performance threshold in MIPS so that you're not getting a penalty. So I think that's just important context to consider, and maybe in the future, because there seems to be a little bit of lack of familiarity with how the overall MIPS program works and how the scoring very much plays into how you're reporting and the associated scoring rules, like the number of measures you have to report on, or what specialty you are within a larger group practice, and the administrative burden of reporting. This is a more complex conversation than just looking at the numbers that are in the MIPS program and then the overall impact it has to physician participation in the Medicare program and access to patient care if we continue to just ding physicians and not create a meaningful MIPS program.
Thanks, Corinne. Just wanted to pause to see if CMS wanted to reflect on those comments from Corinne at all.
This is Lisa Marie. So I just want to note that I hear what everyone is saying with regard to maybe some of the dynamics with regard to, let's say, measures being available or not being available, and how clinicians may choose the measures that they report or that they would probably do the best on for getting performance and meeting performance thresholds. But I just want to note that, just to give some other context with regard to just the measure, and as has been indicated, we proposed this measure for removal in the program. So this measure is currently in 3 specialty sets. And in those specialty sets, family medicine is one of the specialty sets, and there's 63 measures in that specialty set. It's also in the internal medicine specialty set, and there's 59 measures in that specialty set. It's also included in the OBGYN specialty set, and there's a total of 28 measures in that specialty set. So there are other measures that can be selected for clinicians to report on. And again, just because the program, the way it is structured, people, if let's say they choose not to report, if this measure is no longer in the program, they will have to choose to report another measure. And there are other measures that they can report from. And hopefully they may choose measures where, they can see where they can have room for improvement. But again, most clinicians may probably choose measures in which that they will perform best on for their own gain.
Thank you for that, Lisa Marie. Sai, you have your hand up.
Yeah, thank you so much. I think Lisa and the previous commentators' information have answered most of my questions. I was going to comment that it's a little bit hard to make this kind of decision at the individual measure level without knowing the whole measure set. So some information about what other measures are available for a particular specialty for consideration will help us to make that up and down decision or recommendations. And I also want to make a comment that when we talk about top off measure, are we talking about at the intended use level? Here is clinician level, or are we saying a measure is topped out at the population level? Because a lot of the discussion is about individual member, certain subgroup of members. But when we talk about top out, I think we're talking about top out at the clinician level, right? So just want to make some distinction here. Thank you.
Thank you, Sai, for those points. David Seidenworm, and then I think we're going to do a check to see if we're ready to vote. David, go ahead.
Yeah, just regarding the availability of other measures in the measure sets, I think the specialties mentioned were family practice, internal medicine, and OBGYN, and those are primary care, often more generalized practices that do have the option to report, in multiple domains. In the for example, within the medical subspecialties, there might be specialties that only have a limited set of measures. And of course, there are a great many clinicians in the MIPS program who fall outside of those three domains. So I think that although we're perhaps well covered or not within those three domains, because there are specialties within OBGYN as well, that may not allow other more subspecialized clinicians to participate fully in the program.
Thank you for that. So I'm going to just take a minute and summarize what we've heard thus far. This is a measure that CMS is proposing to remove in the proposed rule because it's measuring what has become the standard of care, noting limited opportunity to improve. There was a good discussion about kind of what does this topped out phrase really mean? Is it topped out for everyone? Are there subpopulations, by race and ethnicity, or potentially rural or urban differences that are not being adequately reflected in that topped out assessment? And there was some discussion about the flexibility that's available in the MIPS program to choose measures, and the idea that it's important for us to consider the other measures within a set that are available to select, and that potentially discontinuing the measure may encourage people to focus on measures where there may be more opportunity for improvement. Rosie and Akeem, did I miss anything in that summary?
No, I think you did very well.
Yes.
Yeah. Okay, so let's move to a vote, everybody. Isaac, that means you.
The question should be showing up shortly on your screens. Voting is now open for the measure on appropriate use of DEXA scans in women under 65 years who do not meet the risk factor profile for osteoporotic fracture. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, and B, no, discontinue use. And we are expecting 24 votes. Waiting for two more.
I put my vote in the chat.
Yes, David, I see your vote. Thank you. Waiting for one additional vote. All right. We have all 24 votes. Voting is now closed. We have eight votes for A and 16 votes for B. With 69.57 votes for discontinued use, the committee recommends the discontinued use of the measure in MIPS.
Okay, thank you so much for that discussion and the vote. I think we have one more measure to discuss before we break for lunch. So let's pull up that slide. Great. So this next one is overuse of imaging for the evaluation of primary headache. This is another MIPS measure, and we can move to the next slide for some summary information. So this measure is the percentage of patients for whom imaging of the head, including CT or MRI, is obtained for the evaluation of primary headache when clinical indications are not present. The measure steward is the American Academy of Neurology. And again, this is a MIPS measure. It is a process measure at the level of the clinician. It is not endorsed and has not been endorsed. All required data for this measure are collected as part of the clinical workflow, and it is not in a statutorily required category. So, Lenice, I know you mentioned this measure in your overview. Did you have an additional sort of measure-specific background to give on this one?
I do.
Okay, super. Go ahead.
So CMS recommends maintaining this inverse appropriate use patient safety measure, as it is a high priority measure and aligns with clinical recommendations to limit radiation exposure. In the calendar year 2025 physician fee schedule proposed rule, the specialty specific measure that was proposed for inclusion in the newly established Quality Care for Patients with Neurological Conditions MIPS Value Pathway, MVP. The measure is only one of two specialty-specific measures within the MVP and the neurology specialty set. While this measure is in its second year of the topped-out life cycle, the historical benchmark data indicates improvement in performance from year to year. Also, this measure is considered to be extremely topped out. However, with the inclusion of the measure in the MVP, it may increase adoption of the measure and establish a gap or variation in performance.
Okay, thank you for that. Let's move on to look at the summary of public comments and PI feedback. So for meaningfulness criterion, we had 3 committee members supporting this measure in terms of the importance, the validity, and the specification. Two individuals denoted that the patient journey criterion is met. It reduces unnecessary testing and costs and improves access for patients with a medical need for imaging. And then 2 indicated that the data stream parsimony criterion was met, given that it's a claims-based measure with minimal redundancy in the data stream. No public comments on this measure. So let's move on to kind of our discussion topics. We noted in the preliminary assessment that this measure showed little to no opportunity for improvement for the top 60% of reporting entities. And so how can this measure be used to improve quality for the lower performers? Is continued use of this measure warranted, given that CT and MRI for the evaluation of primary headache is not the standard of care for patients without specific risk factors for structural disease? And are there certain subpopulations more likely to be impacted by the discontinuation of this measure? So those questions are food for thought, but I open it up to the committee for anything you'd like to discuss.
Meredith, you're talking on mute.
Apologies, Michelle Dardis, you have your hand up.
Thanks. This is a question either for maybe the developer or CMS. I think the point about the inclusion in the MVP is an important one, and I wondered if you had any perspective for us on how that might change the measured population from the current measured population.
I will defer to the measure steward, Erin Lee. Are you able to address? I don't know if I'm looking to
check to see if Erin Lee is not on. I understand.
Lisa Marie, this is Joel. Would you be all right if I responded to this?
Yeah.
All right, excellent. Good morning, everyone. My name is Joel. Well, I guess it's afternoon now, depending on where you are. So the going theory here on how we're thinking about the measure of populations being altered by inclusion in MVP essentially boils down to the concept of constraining or at least indicating potential constraint of measure selection by areas of clinical focus and relevance. So the idea is by creating the MVPs, you essentially create a set of measures that are indicated to that exist kind of within the same clinical sphere. And so you're more likely to have clinicians choosing to report into those as a way of more closely reflecting the care and the quality of care that they're providing. The idea here is that because you have a more tightly constrained list of measures within an MVP from which you can select reporting, you're going to have a larger concentration of clinicians for whom reporting on a given measure will be more likely to opt to report that particular measure. And therefore, because you get a larger number of clinicians reporting to it, you get more patients included within it. And so there's less selection bias being fed directly into the assessment of the program. Conceptually, that's the theory. Obviously, the MVPs are still, very much in the early stage. We haven't had a chance to really test to determine that this is, in fact, going to happen. And so this will be part of the monitoring process within the program. But this is why we present this as a possibility for something that may make a measure like this be more relevant as a consequence of how the program is being restructured under MVPs. I think we'll probably be having a discussion a few years into the implementation of MVPs about whether or not that theory has held true, or if we need to reconsider exactly how it's being approached. So that's the thumbnail sketch for version of my response.
Thanks, that helps.
Thank you for that, Joel, and thank you for the question, Michelle. Devika.
I'd be curious to hear others' experiences, but just in response to bullet 2, just in my personal and anecdotal experience, CTs are often ordered in people with primary headaches, regardless of their risk factors. So that's just my experience. I'm curious to hear about the experiences of other clinicians, but I do find that CTs are ordered frequently for primary headache.
Yeah, would any committee members like to respond to that? Nishant, yes.
Yeah, I think you're absolutely right, Devika. I think it's mainly because of ease, and it's some sort of imaging test that the first go-to is a CAT scan. MRIs take, by the time you get approval and everything, it could be weeks, and then you have to, is an open MRI or closed MRI, it takes a long time. So I do. That's where I think it's important to have some sort of check on ordering the inappropriate. I think it's inappropriate in the absence of trauma and a certain limiting neurological signs that would kind of warrant it. So I agree with your assessment.
Thank you. Christine, you have your hand up.
Yeah, I would just say, as a patient who has experienced multiple of them, I worry myself about whether or not they're necessary so often and what the long-term damage could be. So just from a personal perspective.
And Rosie.
And I kind of live on the other side of the fence. I've experienced headaches since the age of like 16 or 16, and I have never had a CT scan for the diagnosis of headache because they have always ruled them either migraines or stress headaches, and basically I've never had a CT scan for it. So I think it's, but it may be where I live, it may be the kind of primary care physicians I've been to. I early on I saw a neurologist, but I have not seen him in years because, but in those days they did not order CT scans that easily. So, but I just, I've never had a CT scan for headache.
Thank you for sharing your experience. Sean.
Yeah, I've practiced in both rural and urban areas, and I would tell you the biggest predictor for getting a CT scanner is whether there's one in the same building. And so I would say that having a measure along these lines sometimes can be a counterpoint also for patients who come in demanding a CT when it's not indicated. And so I would just say that in rural areas where it's tough to find a CT scanner, I bet there's a difference in performance.
Mm-hmm. Great point.
And you're probably right, because I've always lived in a rural area. So.
important to raise. Thank you. Has anyone not had a chance to raise their concerns about this measure or voice support? Okay, I can summarize a little bit what we've heard today. This is one of, I believe I heard one of two specialty specific measures in the neurological conditions MVP. Looking in it's in the second year of the topped out cycle, but inclusion in the MVP may actually change the population of reporters in terms of clinicians reporting and the patients that they see. That is, I think, remains to be tested, but it is a consideration. Devika raised the question about experience committee members have in terms of ordering CTs for people with primary headaches. Questions came up about it being sort of an easy option if there's a machine available, and there was concern about having a check on patient requests for CT and inappropriate scans. Rosie and Akeem, did I miss anything?
I think you covered it.
Very good.
Okay, so I think we can move to a vote.
Yes.
Isaac, over to you. Isaac, you're talking on mute. I may have infected you.
Yes, I was. Voting is now open for the measure on overuse of imaging for the evaluation of primary headache. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, or B, no, discontinue use. And we are expecting 24 votes and wanted to point out that David Seidenworm, you are recused from voting on this measure. We're waiting for one more vote. We have all 24 votes. Voting is now closed. We have 18 votes for yes, continue use, and 6 votes for no, discontinue use, with 75% voting to continue use of the measure in the MIPS program. The committee recommends using the measure in MIPS.
Great. Thank you, Isaac. And thanks, everybody, for that discussion and vote. And thank you for the morning. We've gotten to our lunch break. So if we could please reconvene at 12:45 p.m. Eastern time. So we're shortening your break by 5 minutes so we can stay on schedule. Feel free to turn your camera off. Do not disconnect. Just stay on mute, turn your camera off, and we will reconvene shortly. Thank you, everybody.
Okay, in the interest of just keeping us on track, I think we should probably get started. Meredith, are you on board with that? Cool. All right, let's jump to the next slide, please. Okay, so we are turning to cardiac stress imaging not meeting appropriate use criteria. So this is measure number 10101, the MIPS, for those that are following along in their forms. You can go to the next slide, please. So just a quick overview here. This measure is looking at the percentage of SPECT myocardial perfusion imaging, stress echoes, or CCTA or CMR tests performed in low-risk surgery patients 18 or older for preoperative evaluation during the 12-month submission period. It was stewarded by the American College of Cardiology Foundation, and it is used in MIPS process measure. As all MIPS measures are, it is at the clinician level of analysis. It is not endorsed currently, nor has it ever been. But it is relatively low burden to collect. All of the required data elements are collected as part of a normal clinical workflow at most sites. Further, this measure does not fill a statutory requirement. So with that, I would like to turn it over to, I believe it's going to be Dr. Stephanie Clark to do a quick overview from the CMS perspective.
Good afternoon, everyone. As Brenna said, I'm Stephanie Clark. I'm a pediatric nephrologist and a medical officer in Quinvig. I work mostly with the Division of Quality Measurement. And so this is an appropriate use inverse measure that seeks to decrease unnecessary imaging and overuse. The measure encourages appropriate patient selection for cardiac stress imaging in alignment with clinical recommendations. This measure also addresses the CMS priority of patient safety by avoidance of the associated testing risks, including radiation exposure. While this measure is extremely topped out with a payment year 2024 historical benchmark at 1.34%, the Society of Nuclear Medicine and Molecular Imaging has requested coding updates to allow reporting by those clinicians, which may then increase adoption and establish a performance gap. In the calendar year 2025 physician fee schedule proposed rule, we propose substantive updates to this measure for payment year 2025 with the inclusion of multi-gated acquisition scans to ensure that this type of imaging is not performed on low-risk surgical patients. And Brenna, I will turn it back to you. Thank you.
Thanks very much. Let's jump to the next slide. So we didn't get any public comments on this measure, but there are a few things that are important to note here. The first, I just want to draw attention, we'll put this in the chat as well, but Dr. Clark mentioned that this is an inverse measure. If you are unfamiliar with that term, it just means that a lower score is associated with better performance, right? So instead of looking for a high score, a low score indicates better performance. In general, the PIE feedback was mixed but largely positive. So meeting criteria for meaningfulness in terms of being able to impact quality care. There was a suggestion to add additional testing or imaging to the measure for future years, but not to the detriment of the existing measure. There was a lot of support from the patient journey perspective, the idea that such a measure would prevent unnecessary testing and unnecessary healthcare costs, which benefits patients across the board, making sure that their care is efficient and expeditious, and also, minimizing unnecessary testing that may add to stress for a patient. As I mentioned before, there's also agreement in terms of data stream parsimony. This measure is aligned with most current clinical data flows, and there don't seem to be any redundant measures in the program. There were some concerns around the measure's reliability and the ability for providers to continue to improve on this. And then there was one commenter that had concerns that this measure might lead to the opposite problem of actually leading to an increase in testing. So I will invite the committee members to speak on that, but we can go to the next slide here as we start our discussion. And so I kind of wanted to just jump in and sort of get to the point. So we heard a lot of really positive feedback about this measure, and I'm curious whether any committee members have concerns or questions about this measure that we need to talk through. Go ahead, Corinne.
Yeah, I actually touched base with the measure developer, ACC, to get, more feedback. And they are supportive of removal of the measure from the program. While the measure aligns, the removal does align with evidence-based practices that discourages unnecessary preoperative cardiac imaging for low-risk surgery. And from what they know, too, there's little room for improvement on the measure. It also is the measure is really extremely challenging to implement and difficult to calculate a measure of low risk where no testing is needed versus low risk, because ultimately they believe clinician judgment may be a factor, and it's not something that's easy to capture in a measure. And by removing this measure, it actually the hope it would allow for cardiac specialists to focus more on some more meaningful and high value practices, and aligning with other choosing wisely initiatives that also advocate for avoiding for unnecessary medical tests and procedures.
Thank you, Corinne. Any other comments from the committee? Yeah, go ahead, Scott.
Thank you. Reaching out to our cardiologist, there was a concern for, what are the indications for the preoperative testing, and are they well defined? And I think, to echo what CMS said, some of this is physician judgment. So, there was reluctance to accept this measure on the part of our cardiologists.
Thank you for that. Do we have any feedback from our patient participants about this measure? So putting into perspective the appropriate use criteria for pre-op imaging. Go ahead, Rosie.
Well, I guess I agree with what was said, and for the same reasons, because I think that it's part of the patient journey. It's one of the things that cardiologists, make decisions on, and with patients, on what to test for, and when to use certain tests and at different times, and but then I've helped hospitals develop perioperative evals, and this was not some of the imaging that we looked at or required in those perioperative programs. So, unless there was unless the cardiologist requested it, it was not something that was being requested from perioperative programs.
Got it, Rosie. So to make sure I understand your comment, it sounds like, sort of as a patient, you see the value in this measure, that it aligns with what is important vis-a-vis the patient journey, but that you can see how such a measure might have an impact on shared decision making.
Yeah, I guess, yes.
Okay.
But I think that it needs. I'm not sure we need this measure. I'm not sure, if we need the measure or not, because it is part of the, when I meet with my cardiologist, if he, I would expect him to, I've had some of these tests, but only because of other situations.
Got it. Thank you. Jessica.
Thank you. And I would just echo and agree with what Scott was saying previously. And to that, I would just add that there's great heterogeneity in the types of surgeries that they're talking about too. And that's also a concern. So my understanding is that it's all low risk non-cardiac surgery, which varies in complexity and would have different implications for inclusion as well.
Thank you very much. And I see Mark in the chat. Thank you for your comment. You've not had cardiac issues, but from a cancer perspective, you see the frontline oncologist insights as the better determinative factor. Thank you for that. From a disparities or health equity perspective, hearing that the comments so far, it sounds like largely thinking that this may not be essential for the goals of the program, but are there any specific patient groups or subpopulations I'm thinking either in terms of sociodemographics or in terms of multiple chronic conditions. Are there certain subpopulations that are more likely to be impacted by this measure in terms of benefits or burdens that are worth considering before we take this to a vote? Go ahead, Stephanie.
So I went out and looked at the specification because I'm specifically interested in how a low risk surgery patient is defined.
Okay.
In my area, there can be lots of low risk people in Alabama and they're low risk because they have no medical history that they know of. They haven't seen a doctor in 20 years. And then they go to have what should be simple surgical procedure, and they don't fare well. It's concerning to me how we would define low risk surgery patients from a coded data set, how that would be gleaned out of the information that's provided. If all we're talking about is claims-based data, I just don't know how you would determine that and determine it appropriately, because that whole dual eligibility in my area, we have almost none. And I have very significant issues, lots of patients who are uninsured or lots of patients who have no healthcare provider whatsoever, and they don't show up in the risk adjustment done by CMS. It's just not there. So anyway, I'm not sure. It gives me a great sense of pause to when I look at this and go, how do you limit this and how do you define low risk surgery patients?
Thank you, Stephanie. That's a great perspective. I'm wondering if anybody at CMS or if the measure steward has any comments on anything that's been stated or any feedback they'd like to share.
And Brenna, I just wanted to point out that, sorry, Lisa Marie, go ahead.
Sorry, go ahead. Go ahead, Dr. Clark.
No, I was just going to point out that that Joe had put in the chat that the risk is based on the type of surgery, not the condition of the patient. So I just wanted to point that out, but I'll turn it over to Lisa Marie.
Yes, and actually, Joe Allen is actually part of the Measure Steward team. So if he wants to add any information relative to what was just commented on from the panel, Joe, please add anything you'd like to add.
Sure, I think everybody stated well. It is based on the risk of the surgery. So these are ones that will not have a vascular impact on the patient. And so, things like cosmetic surgery or hand surgery, it's not going to impact somebody's heart. And so that's the basis for this measure. As was stated earlier, we do believe there is only little room for improvement at this point, and it is a little bit complicated measure because of the way it's kind of an inverse measure, as well as you're looking for patients that would have, had these types of surgeries. And so it's not, straightforward. So we do recognize if folks don't feel like it is, but it is aligned with choosing wisely and other types of efforts. And so, so happy to hear the feedback.
Thank you,
Joe. We
Joe.
also received a question asking if cancer surgeries are excluded from the measure.
They're by type of surgery. We do list all surgeries, all different types of surgeries, including cancer. Things like skin cancer removal is not going to have an impact on the vascular system, but other types of cancer surgeries obviously very much would. So just like all types of surgeries, we look at more of the impact on the cardiovascular system, not on like the category of surgery in whole.
Go ahead, Jessica.
Just for clarification, and so it's an adjustment then and not an exclusion based on cancer or based on surgery type rather?
It's based on surgery type, not based on like, does somebody have cancer or something like that. There are all sorts of reasons why people might undergo cardiovascular imaging outside of the particular surgery, and that's not meant to exclude that. It's just for those that have the surgery and have no other reason for testing. So yeah, you might have heart failure related to your cancer or something else where you undergo imaging, but this is to take care of like people going for hand surgery and being sent for a cardiac eval before, just to double check, but that's not going to have an impact on your cardiovascular, or in the case of cancer, it'd be like a skin cancer removal where you're not impacting the cardiovascular system.
Okay, sorry. And so then those patients with heart failure, say undergoing a surgery, they would not be excluded. There would just be a risk adjustment
It's
applied.
not really a risk, it's a type of surgery, so it's not a risk adjustment, it's the risk of the surgery to the heart and circulatory system. So different than typical, like when we say low risk, many times we mean risk adjusted or the types of profile of the patient, but this is purely based on the impact of the surgery. And I think somebody was asking about if it's in 30 days. It is 30 days of the low risk surgery.
Okay, thank you.
Okay, does anyone else on the committee have any questions, especially in response to the clarifications from the measure developer? Christine, I saw your comment in the chat. You're a cardiology patient and you agree with Mark's comment about your own cardiologist. See that, thank you. Okay, not seeing any additional comments here. Akeen and Rosie, are you okay with me summarizing and taking this one to a vote?
Definitely.
Yes.
Great. All right. So per the AMA at the beginning of the discussion, the ACC is largely supportive of removal or recommendation for a removal, citing little room for improvement and that it is relatively difficult to implement. So that is from the reporting side. When we talked about the measure from a patient perspective, we saw that the measure might have some value, but the impacts on shared decision making sort of outweigh that, making it unclear whether this measure has a ton of value in the program. We heard concerns about the wide range of surgery types included in the measure and how low risk is defined. We heard that from the perspective of rural hospitals or hospitals where there are lots of uninsured patients, that they would be unknown. A lot of the surgical risk would be unknown. So even though the actual risk is by surgery type and not by patient history, that patient history would still not be reflected in the record for these measures. I wanted to just see anything that I missed, any points that anybody wants me to make that didn't make it in here.
Brenna, I don't know if it's possible with the measure steward to actually convey if they are in support of the removal of the measure. The reason why I want them versus the AMA to make the inclination is because for the 2025 physician fee schedule proposed rule, there actually proposed changes to the measure. And so if the steward, Joe, I don't know if you want to convey the sentiments of the steward in regards to the status of the measure, whether being remaining in the program or being removed, but I would rather have the actual steward convey the sentiments versus AMA speaking on behalf of your organization.
Sure, I'd say we're neutral. We're happy to have it included if there is value that the panel feels, but we also agree that there may be little room for improvement.
Great, thanks, Joe.
Yep, and thanks, Lisa Marie, for bringing that up. It's super important to get that clarification. Appreciate it. Okay, then let's take this to a vote. Isaac.
Voting is now open for the measure on cardiac stress imaging not meeting appropriate use criteria, preoperative evaluation in low-risk surgery patients. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, B, no, discontinue use. And we are expecting 24 votes. We're waiting for 2 more votes. We have all 24 votes. Voting is now closed. We have 5 votes for continued use and 19 votes for discontinued use. With 79.17 votes for discontinued use, the committee recommends discontinuing the measures used in the merit-based incentive payment system.
Thank you, everyone, and thank you, Isaac. Let's go to the next measure. All right, we are now turning to another MIPS measure. This is appropriate follow-up imaging for incidental abdominal lesions. Go to the next slide. So this measure is looking at the percentage of final reports for imaging studies for patients 18 and older with one or more of the following noted incidentally, with a specific recommendation for no follow-up imaging recommended based on radiological findings. So those things include cystic renal lesion that is simple appearing, adrenal lesions less than or equal to 1 centimeter, adrenal lesions greater than 1 centimeter but less than or equal to 4 centimeters classified as likely benign or diagnostic benign by unenhanced CT or washout protocol CT or MRI. With in and opposed phase sequences or other equivalent institutional imaging protocols. That's a lot of very technical language. The sort of plain language description is that this is just looking at the final percentage of reports for imaging studies for adult patients where an abdominal lesion was found. Okay, so we can cite that this is stewarded by the American College of Radiology. It's used in MIPS, and we can jump to the next slide here. As you can tell, it's a process measure at the clinician level of analysis. It is not endorsed, and it never has been, but there is indication that the data are collected as part of normal clinical workflow, and it does not fulfill a statutory requirement. So I would like to turn it now to Ron Klein for CMS's overview of the measure.
Yeah, good afternoon, those of you on the East Coast. Good morning on the West Coast. So CMS recommends maintaining this appropriate use / overuse measure for both collection types in the MIPS CQM and the Medicare Part claims data, as it is a high priority measure. The measure is important to ensure unnecessary follow-up of procedures are avoided. They may be costly and burdensome to patients, and I might add additional radiation as well. The 2024 historical benchmark for the MIPS CQM version of this measure has a performance rate of approximately 79%. The measure in its third year of the topped-out life cycle. The 2024 historical benchmark for the Medicare Part B claims version of the measure has a performance rate of 54.1%, indicating performance gap. CMS is recommending the retention of this measure in MIPS due to its importance for radiologists, specifically for diagnostic radiology, which has limited available measures. The measure is one of 6 measures within the diagnostic radiology specialty set.
Thanks very much. Let's go to the next slide. So again, we didn't get any public comments specific to this measure, but the feedback that we got on the initial PIEs was largely positive, citing that the measure has the ability to reduce inappropriate use of radiologic studies and subsequent healthcare costs, support for the patient perspective that it prevents unnecessary testing and the psychological stress that's associated with having to undergo additional testing for incidental findings. Although the concern that was brought up was around the potential for limited shared decision-making with patients when lesions are found. In other words, the concern that if a patient themselves wanted to pursue additional testing on a lesion, that they would be disinclined to have that conversation with their providers if they were trying to meet the measure. But from a data stream parsimony perspective, largely supportive, seeing as the data use is relatively non-burdensome and the measure itself doesn't really add to any redundancy with other measures. Let's jump to the next slide. So I'm interested in any and all thoughts, but just to get the discussion started here, we do, sort of just want to understand overall if this measure continues to meet a need in the MIPS program, as it sounds like it does from the CMS perspective. And then just to understand, the extent to which the advantages of the measure that we cited on the last slide outweigh the perceived impact on shared decision-making with patients. So with that, I will open the floor. Go ahead, Corinne.
Yeah, I'll just say we support CMS's perspective that this measure is important to maintain. And from my understanding and review of the literature out there, there is still a gap in care. While it might show up as topped out in MIPS, that's not what the literature is showing, and that there still is significant room for improvement and better adherence to the American College of Radiology guidelines. So adherence to the guidelines, it remains suboptimal, and that there's room to be made for improvement. Thank you.
Thanks, Corinne. Amy.
I would just comment from our health system, this is a really active topic, and we have diagnosed, I can't tell you how many patients and saved lives because of it. So I would definitely advocate to continue. Thank you.
Amy, can you just clarify a little bit? You've been able to, by ordering follow-up imaging or by not ordering follow-up imaging?
By not following. So we've identified lesions and not had to retest and take up capacity and access with retesting.
Thank you very much.
You're welcome.
Jennifer.
I support retaining it as well for all the good reasons previously cited. I will just comment from the patient journey perspective. Understanding that you've had an incidental finding is also cause for psychological stress. So equipping clinicians and care teams with the tools to talk about why something was found and why you're not doing any follow-up is just as important as avoiding that unnecessary follow-up. So when I think about things from a quality improvement perspective, I think there are tools and scripts and things that we can support clinicians so that they can reassure patients about why further follow-up is not only not necessary, but in fact could increase risk and could take up all of the resources that were just described.
Great point, Jennifer. Thank you. Rosie, go ahead.
And I agree with the psychological stress because I've dealt with this, and the follow-up with my physicians and the discussions we had were more important than any imaging that they could have done. So it was seen on a CAT scan that was done because of my amputations in my leg and the MRSA, but yet then the follow-up with my physician and with an then the discussion put my mind at ease that this was not something to follow. It was not something to worry about, and that it was just something that showed up, but it was not something to have a concern about and to have more testing. So this was definitely, when I read this one, and it was one that I was doing the pie on, and it was like, this is my life. and I've had this happen multiple times with CT scans, and because of all the CT scans I've had of my leg and having a lack of leg now, and so this is this is a part of who I am, and this happens, and so it's not doing more and more imaging would that would even cause me more stress because you worry about it.
Thanks very much for that perspective, Rosie. And as always, thank you for being so generous with sharing your personal experience. Christine.
So I was pretty much finished. I back this. I think that as a patient who has multiple images, I've grown to really, I think in my younger ages, I asked for them all the time. I wanted to see if there was, and I wanted to, really try to monitor things at a closer level, but didn't realize the impact that all of this could have. So I would say that I agree, but I think that really I agree more around the education with the patient community on why there would be no follow-up, and kind of explaining this and really educating how often it needs to be done as well.
Thank you. David.
Yeah, I'm good with all the comments that were said. I just wanted this come up in a number of discussions on MIPS that we talk about sometimes that there's a limited number of measures. I don't think we're doing this in this case, but I think we should just be mindful that we shouldn't be hanging on to measures if it's a poor measure, which I'm not saying this one is, just because there aren't many measures in the specialty. That's something that I think needs to be addressed in the MIPS program as a whole. So I just think as a group, we just need to continue to stay focused on that. But I'm supportive of everything said around this measure.
It's a great reminder. Thank you. Christine, I see your hand is raised. Is that just a relic from before, or do you have another comment?
No, sorry, from before.
No worries. Okay.
And just this is Lisa Marie. Sorry, I just want to give context just to the comment that was just made. So for this particular measure, it's in one specialty set, and it's in the diagnostic radiology, and there's only 6 measures in that measure set. So again, as I noted previously, and MIPS are required to report at least 6 measures. So in this case, this is just hitting that threshold.
Thank you. Okay. I'm not seeing any other hands, and I think we've largely been we're seeing a lot of agreement so far, so I don't want to drag out the discussion, but as I'm summarizing here, please feel free to jump in, and Rosina Keene, let me know if you want to raise any other aspects of this discussion. But we have largely heard positive feedback about this measure in terms of retaining. I think we heard from the AMA that there is still, based on the literature, that there's still room for improvement on this measure. We've heard from Amy that health systems, this is still a really active conversation, and there is a sort of demonstrable improvement in cost reduction and in freeing up resources by adhering to this measure. And we're hearing that overall, that the concerns about the psychological stress on patients isn't limited to follow-up imaging. It's anytime you see that you have an incidental finding on radiological imaging, that there is some stress associated with that one way or the other. So several members of the committee brought up the importance of, from a quality improvement perspective, adding an education component, helping clinicians educate patients both on the risks of radiological overuse, and then also on kind of the true meaning of an incidental finding to help reassure patients about what's actually going on. And it sounds like overall everyone is sort of stating that the importance of this measure outweighs any potential negative impacts thereof. So with that, I will ask if anybody feels like I have missed or underrepresented their feedback. Okay, then Isaac, let's take this to a vote.
Voting is now open for the measure on appropriate follow-up imaging for incidental abdominal lesions. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, or B, no, discontinue use. We're expecting 24 votes with 1 recusal, and that recusal is David Seidnor. We have 21 in, waiting for 3 more. We have all 24 votes. Voting is now closed. We have 22 votes for continued use and 2 votes for discontinued use. With 91.67 voting for continued use, the committee recommends the continued use of this measure in the merit-based incentive payment system.
Thank you, everyone, and thank you, Isaac. Let's move on to the thyroid nodules measure. Okay, so now we are turning to appropriate follow-up imaging for incidental thyroid nodules in patients. This is measure 7001C MIPS for those following along in their materials. Let's go to the next slide, please. So this measure is looking at the percentage of final reports for CT angiography, or MRI or magnetic resonance angiogram, MRA studies of the chest or neck for patients 18 or older with no known thyroid disease that have a thyroid nodule that is less than 1 centimeter, noted incidentally with follow-up imaging recommended. This is another measure stewarded by the American College of Radiology used in MIPS. It is a process measure at the clinician level of analysis. It is not currently endorsed and it never has been, but the data are collected as part of normal clinical workflows at most places. And this measure is not meeting or is not required by statute. Okay, with that, I would like to turn it back to Dr. Stephanie Clark from CMS to give their overview.
Thanks, Brenna. This measure is an appropriate use inverse measure, and the purpose of the measure is to align with clinical best practice and decrease overuse, including unnecessary follow-up imaging and procedures that may be costly and burdensome to patients. This measure also addresses the CMS priority of patient safety by avoidance of the associated testing risks, including radiation exposure. While the MIPS CQM version of this inverse measure is in its 6th year of the topped-out life cycle, with a payment year 2024 historical benchmark of 3.73%. As with the previous measure, this measure is important for the field of diagnostic radiology, which has limited available measures in MIPS. And with that said, I do also just want to acknowledge David's comment from the previous discussion, but just to let you know that it is supporting the field of diagnostic radiology. And I will turn it back to you.
Thanks very much. Let's go to the next slide. So again, no public comments to reflect on here, but overall, the PIFORM feedback was overwhelmingly positive. The measure was considered to be important and that it reduces the overuse of imaging, which reduces costs and frees up resources so that patients that need that imaging have access to it. Again, reduces burden costs and psychological stress for patients, and a general agreement of low burden for data collection. So we can jump to the next slide here. So I think we probably don't need to talk too much about the second bullet because it is very similar to what we talked about with the prior measure, and I imagine that the conversation will be similar. Having said that, if there's anybody who feels very strongly that there is a difference in terms of the thyroid nodule follow-up, then the abdominal lesions, please feel free to bring that up. But I think what we really just want to get at here is, whether this measure continues to meet a need. And it sounds like from the CMS perspective that it does. But I'm interested in opening the floor for the committee. Okay, seeing none, I think it would be interesting then instead to see if there's anybody on the committee, just even by a show of hands, is there anybody on the committee that has any concerns about keeping this measure in the program? So feel free either raise a hand or just to chime in the comments.
Oh, but I just want to note that Jennifer Lundblad had a comment of asking CMS to say again the current performance and what the gaps are.
Thanks, Kate.
What gaps there are.
So for the current benchmark, the performance is at 3.73%. So again, for an inverse measure, the lower, the better. That's where it is currently.
Does that answer your question, Jennifer, or did you have a follow-up?
So it does, and it strikes me that one of the differences between this measure and the similar one in some ways that we just looked at is that there was a bigger performance gap in the prior measure. This one is doing much better overall, if that makes a difference in our deliberations. Thank you.
Thanks very much. Do other members of the committee have thoughts on that? Christine, thank you. I see you're echoing your comments on the last measure. Do other members of the committee have opinions related to the performance on this? Go ahead, Corinne.
Yeah, like the other measure, the literature also is showing that there is a significant performance gap in the appropriate and following the guidelines related to this measure that American Academy of American College of Radiology has published. So we recommend to maintain this measure in the program.
Thank you very much. Go ahead, Thomas.
So if there's a significant performance gap in the literature and the measure's not capturing it, how does the measure need to be changed so it can capture it? I mean, it would seem like the measure's not effective unless it's somehow adjusted so it can capture it.
Yeah, I suspect that it has to do with voluntary reporting, and so there's probably a selection bias, but I will invite CMS to speak on that if there's any other information you might provide to suggest why we would see a difference in the literature compared to the performance scores.
I think, Brenna, I think you're correct. There, again, well, actually, I wouldn't say there's a selection bias unless, for example, radiologists want to report other measures other than the ones that are within the measure set. So the measure set, there are 6. So they'll be required to report all 6 measures. But again, those who choose to report those measures, again, are probably the ones that are reporting, that are doing better, which is why they want to report for those measures maybe versus outside of the measure set. But there is more than likely probably some selection bias going on there.
Does that answer your question, Thomas, or do you have any follow-ups? And if you're replying, Thomas, you're on mute.
No follow-up.
Okay, thank you. Christina, go ahead.
I think one thing I'm struggling on with the measure sets that have fewer measures where it's likely that all the entities reporting are reporting on all the measures is that piece about selection bias that we've talked about and how that impacts the topping out of a measure. It sounds like this topic is important. There are deviations being seen in practice, but it's not being collected in the measure. And so I'm having a little bit of trouble wanting to support this particular measure and its continuation, given that it's not aligning with the measure and it's part of a smaller bundle where more entities reporting or selecting this measure.
Thanks, Christina. And I think that probably touches on David's comment on the last measure too, right? So does anybody else have any comments? Or David, did you want to chime in again here on?
Yeah, no, the same as before. I'm just going to jump in real quickly, essentially repeating what Lisa Marie has said. And I think this is the nature of physician choice and quality measurement. If you can pick which measures you're going to report, you're probably going to pick those that you're going to do the best on. That just is human nature. So what we're talking about is an inherent. It is. I won't say it's a flaw or an advantage. I'll say it's inherent to the MIPS program the way it's structured now. As long as people who report have complete choice in which measures they report, this is going to be an issue that we will be dealing with.
Thanks, Ron. Rosie, go ahead.
It's interesting because my son had a bike accident and he ended up having to have imaging of a CAT scan of his neck because he damaged one of the vertebrae in his neck. And when they did that CAT scan, they found a thyroid nodule, and that nodule then was treated because he was having other issues that they hadn't figured out what was wrong with him. So, so he was falling through the gap of not, but because he ended up having this bike accident and having a CAT scan because of the bike accident, then they found the thyroid nodules and found out that was the cause of his other issues that he was having. And so it was kind of interesting that it was kind of the backwards of what this is talking about, but yet, it was imaging, if somebody would have done, the appropriate imaging at the time that when he was having these symptoms, maybe he would have found this out earlier. So
yeah, it's a good sign that sometimes those incidental findings can lead to a diagnosis that's helpful. Do you know?
So he ended up with a diagnosis that was helpful because of incidental imaging.
Yeah, I was going to ask if you know offhand, and please feel free to not answer this if you don't want to, but do you know if the findings were under that 1 centimeter threshold or if they were above it?
Under.
Under, okay.
Yeah.
Thank you.
Hi, this is Lisa Marie. I also just want to provide some clarification because I know there's discussion about like the measure set. So there's a measure set, it's relating to radiologists, and there are 6 measures within that measure set. So if someone chooses to report that specialty set, they report on all 6 measures. If, let's say, a radiologist does not want to report the specialty set, they can report measures outside of that, in which they would have to select 6 other measures to meet the requirement for MIPS. I just want to make that clarification just because I know that there's some dynamics going on with like requirements and like, so within the specialty set, there are 6 measures. So if this measure was removed, it would go down to 5.
It sounds like what might be helpful just from a, not that it's actionable at this moment, Lisa Marie, but it sounds like what might be helpful is getting some thoughts from the committee on if this were to be recommended for removal, like what might replace it, what would be a better measure? Is that information that would be worth getting at?
I think any type of information with regard to, let's say, what type of measure should be developed, that would be helpful because on a yearly basis, we also have an annual call for measures in which we're requesting developers to look at potential gap areas where, let's say, we want more measures to be developed. So this would be a potential area. I know the steward, the measure steward for this particular measure is on the line. So Brendan or Judy, I know that you are developers for this measure and the previous measure. So I don't know if you have anything to add, but I know that any types of measures or recommendations are always helpful because we're always trying to fill the gaps or increase measures so that others can report, let's say, on more measures versus a limited number of measures.
Hi, this is Judy Burleson at the American College of Radiology. Thanks for the conversation and the support for both the measures that we have under review. The ACR does continually develop measures and attempt to have them included in the program, either as a MIPS measure or through a registry measure. So we are continually submitting them to CMS for review and acceptance as new MIPS measures. And we'll be having conversations again shortly this year to discuss measures and areas for development. But it is a lengthy process, lengthy and expensive process to do that. But we are open to new ideas that this committee might have and others as well as to ideas for new measures to include in the diagnostic radiology specialty set. And one other thing I wanted to mention, which I know that Dr. Klein made comments earlier about the limited measure set, but there is also a proposal for 2025 under the physician fee schedule that CMS has proposed that to recognize certain medical specialties like diagnostic radiology who may be at a disadvantage due to fewer available quality measures and measures being topped out and capped at 7 points and looking on a case-by-case basis as whether or not those measures could have their 7-point cap removed and allow for a 10-point scale.
And I'll just add that I've been working with ACR over the last couple of years, maybe last year, to try to develop measures, ones where both CMS and ACR are on the same page. And that's, as you said before, that's a long process, but we've been working on it.
Thank you
Yeah,
for
thanks,
that.
Judy, for your comments. Appreciate that. So as Judy noted, so in our proposed rule, because we do recognize that there are some measures that may be top-down, have top-down performance, but because there are limited measures within the specialty set, on a case-by-case basis, we want to have the ability to review them to determine if, for example, they should have the ability to be scored on the full scope of the full scope of points that are available, for example, would be 10 points. And so in this case, for example, there are limited fixed measures. And so if there are top-down measures, this would allow clinicians that they're reporting this particular specialty set to be able to have more achievement points versus the limited where right now we have limited points for top-down measures. So thank you again, Judy, for calling that out. But this is really important because this is actually one example of specialty set that we are looking at in terms of, you know, applying this new potential policy, again, if it's finalized, on how it can help start out with performance.
Thanks, Lisa Marie. Okay, I think we've probably reached the natural end of the discussion. So I'm going to go ahead and summarize here unless Akina or Rosie disagrees.
No.
Thank you. All right, so what I have heard in terms of the sort of in favor of retaining is that it is in general a pretty important measure for diagnostic radiology. Overall, there is higher performance on this measure than on the abdominal lesion measure, but for the literature, there is still a performance gap in general. We see that the kind of difference in the performance that we see from the measure versus in the literature is largely driven by just the nature of the MIPS program and voluntary reporting. And then just sort of the opposite end of the spectrum, we heard concerns about the fact that the measure doesn't seem to have the potential to actually drive improvements in the quality of care, given that only high performers are choosing to report on it. And Rosie also pointed out that sometimes incidental findings can lead to an actionable diagnosis in certain exceptional cases. And then we heard quite a bit from CMS that this measure is one of 6 that providers have to choose from in this category. So removing it would leave them with 5, which is just another consideration to be balanced against David's feedback from earlier about whether it is worthwhile to keep a measure in the program just because it is one of very few if it is not helping to achieve the goals of that program. Are there any nuances or topics that I missed that folks would like me to summarize here? Okay, hearing nothing, I will turn it to Isaac to bring us to a vote.
Voting is now open for the measure on appropriate follow-up imaging for incidental thyroid nodules in patients. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, B, no, discontinue use. We're expecting 24 votes with 1 recusal, and that is David Seidenberg. Waiting for 1 more vote. All right, we have all 24 votes. Voting is now closed. We have 23 votes for continued use and 1 vote for discontinued use. With 95.83% voting for continued use, the committee recommends the continued use of this measure in the merit-based incentive payment system.
Thank you very much, everyone, and thank you, Isaac. Let's jump on to our next measure, which is related to maternity care. Okay, so switching gears a little bit, we are now looking at elective delivery without medical indication at less than 39 weeks, which is measure number 41901 C-MIPS. So let's jump to the next slide, please. So this measure is looking at the percentage of patients, regardless of age, who gave birth during a given 12-month period, who delivered a live singleton, which is to say a single baby, so not twins or multiples, at less than 39 weeks of gestation and had elective deliveries without a medical indication for doing so, either by C-section or induction of labor. It's stewarded by CMS and used in MIPS. It is an outcome measure at the clinician level of analysis. It is not endorsed, but all of the data elements are collected as part of a clinical workflow, and this one is not part of a statutorily required category. So with that, I'm going to turn it to Dr. Marcia Smith from CMS to give their perspective.
Thank you, Brenna. I'm Dr. Marcia Smith. I'm a medical officer in the Quality Measures Value-Based Incentive Group. And the rationale behind this measure is to reduce the risk associated with early elective deliveries, such as prematurity, increased neonatal intensive care unit admissions, and higher rates of cesarean section. The measure aims to improve maternal and neonatal outcomes by discouraging unnecessary early deliveries. This measure is a high priority measure and addresses a CMS priority clinical area, which aligns with clinical recommendations discouraging non-indicated elective delivery before 39 weeks gestation, minimize both maternal and neonatal risks and complications. This inverse measure was finalized for inclusion in the Women's Health MIPS Value Pathway, MVP, and is included in 2 specialty sets. In calendar year 2022 physician fee schedule final rule, CMS finalized substantive changes to the measure, which require a new benchmark to be established. But there has been insufficient data to establish a benchmark. The finalization of the measure for inclusion in the Women's Health MVP may increase the adoption of the measure. Also, the measure is similar to a measure in the Core Quality Measures Collaborative Measure Set and the Medicaid Core Set, facilitating alignment across these programs. That's it. Thanks.
Thank you very much. Let's go ahead to the next slide, please. Okay, so for this maternity care measure, we did receive one public comment, and it was largely related to concerns around the measure's topped-out status. They suggesting that the measure may have limited utility in driving improvement in this area. And that same person noted that the same measure had been recently retired from the IQR program by CMS. From the committees, oh, go ahead, Dr. Smith.
I had a question about that comment being topped out because on the preliminary assessments, there was no available data this is for the MIPS program. So there was like no available data for several years. Are they referring to topped out in other programs? Because I believe there was a reference to the Joint Commission, which was for hospital. If you could clarify that, that would be helpful prior to the discussion. Thank you.
Yeah, the public comment itself was not specific, so we're reporting it out to you from what we heard. We were actually going to turn it to CMS to see if you could comment on that. So it's good to hear that you have the same question. I think that is valuable. From the PIE forms, we largely saw support. So it is seen as being important to reduce elective delivery prior to 39 weeks without a medical indication, and that it prevents increased and unnecessary costs for patients as well as poor outcomes. In general, it makes sense given the timing of the patient journey, and there were no concerns raised in terms of data stream parsimony. So we can go ahead and jump to the next slide. So knowing that we have limited data for this measure for the MIPS program, which is where we're discussing it at this point, but that we did receive a public comment suggesting that it was topped out in another program. I think what's really important here is maybe to think more from a face validity perspective about whether there are any patient subgroups for whom performance on this measure may continue to lag, or if there are certain settings where scores on this measure may be a little bit worse than in others. So I'm just looking at disparities in the way that this care is delivered. Okay, hearing nothing there, I'll pose the second. Oh, go ahead, Akeem.
I guess now I'm a little confused. So I did not do the preliminary assessment for this particular measure, and I'm a little confused about what data were presented to folks to suggest that performance was topped out. If they're focused on the IQR measure, I do think that measure was removed from the IQR program, but there is a different measure of cesarean births in the IQR. It's an ECQM. That's a slightly different focus here. So can you kind of help clarify? I'm a little lost.
So this is Lisa Marie with CMS. I just want to at least so with MIPS, I can't speak for the other CMS programs, but at least for MIPS. So as indicated in the talking points or the introduction, it was mentioned that this measure went under substantive changes in 2022, and we haven't been able to establish a benchmark just yet. So that means if we can't establish a benchmark, that means that there hasn't been enough of clinicians or groups reporting the measure. I will note that in 2021, 2022, 2020, 2021, 2022, we provided extenuating circumstances exceptions where people did not have to report due to the pandemic or the public health emergency. So given that, again, we use historical data to establish benchmarks. So during the pandemic, the measure was not required. Well, again, no measures required reported, but we allowed groups to request an extenuating circumstance and not be able to report from it. So due to those dynamics, there's limited data as to why benchmarks have been performed or been established. I just want to give that context, just again, where we're at in terms of looking at data and other things. So no one reported this measure or chose not to due to whatever circumstances they were facing during that time.
Yeah, and I'll note, Akeem, that the comment that came through wasn't from a committee member, and they weren't citing the PA. It looked like they were citing their own experience working with other programs. So take that as you will. I think the question maybe to raise here is related to the second bullet, and it may be worth starting with CMS is, if this measure were discontinued, would it leave a gap in the program related to maternity care? Can you give us some context around, the role that this fits in the program?
So the measure one, it is a high priority measure within the program. I will note that it's in the focusing on women's health MVP. So if it was removed or removed from that particular MVP, and just with measures being included in MVP, it also increases potential chance of adoption of the measure or more uptake of the measure. I will also note that this measure is also in 2 specialty sets. It's in the certified nurse midwife specialty set and the OBGYN specialty set. In the certified nurse midwife specialty set, there are 13 measures. In the OBGYN specialty set, there are 28 measures. So I will say that the bigger impact would be to the focusing on women's health MVP. And again, this is a high priority area for CMS, and this would have significant impact on the picture MVP. And again, this is an area we're really trying to focus on within CMS. So this is extremely important, women's health.
Thank you. That's great context. Dr. Klein, go ahead.
Yeah, just I don't know, a philosophical comment, if that's the right term. So welcome to our world. The one that, this is the question we struggle with all the time, which is, is the performance improvement there, because this was a gap before, is the performance improvement there because the measure is there? Or has the standard of care now changed and this will remain this way even if we remove the measure? So in this particular case, is this decrease in elective delivery because of the quality measure there, and which means it'll go back in the other direction if we take it out, or is it just that the world has changed? And we struggle, from a big picture perspective, for a lot of these measures where the results are very good, we struggle with that all the time. And I don't have an answer for you, unfortunately, but it is the struggle. It is part of our conversations.
Thank you for that. Jennifer.
Yeah, great. Thank you. In focusing on the second question, does it leave a gap in the program related to maternity care? I'm not sure this is a gap, but what comes to mind for me is the maternal health crisis in rural communities. If you are having a baby in a rural place in America, it is harder and harder to do that anywhere near where you live. And so keeping these standards, I absolutely understand and support the safety of not having elective deliveries without indication at less than 39 weeks, but also recognizing that the increasing challenges of keeping that safety net availability there for rural. So ensuring that rural hospitals and clinicians can participate in perinatal collaboratives as they prepare for the CMS birth-friendly designation, and supporting that so that I guess my comment is the measure doesn't exist without context, and that rural context is one that we should be paying a lot of attention to, so that women, that people can safely have babies in the rural parts of the country.
Thank you so much for keeping the rural perspective front and center, Jennifer. I appreciate it. Michelle.
Hi, thanks, Michelle Dardis. I'm from the Joint Commission, which has the other measure of elective delivery. And so I wanted to call out just one difference between the measured populations here that might be important for the committee, is that measure that was referred to as topped out looked at a population of gestational age greater than 37 weeks and less than 39 weeks, which is a different population, I believe, than measured by this measure. So I wouldn't consider those testing results to be synonymous. That measure was retired due to topped out status for an extended period of time, but it's not the same population.
Well, that clears up a lot, Michelle. Thank you. All right, great. Rosie, go ahead.
Well, first of all, I really appreciate the rule setting comment, but I also, I lived through this 45 years ago, where I was having a baby 8 weeks early because at that point they didn't know I had uterine cancer, and so I had uterine cancer and I was delivering early, but all around me, because it was the week before Christmas, all these other women were having elective deliveries. And so I was trying to keep my pregnancy and was so worried that I was going to lose my child and that she was going to have all kinds of disabilities and things if she did survive, and that all around me, women were having elective deliveries. So I believe that if we would put this out there in the world again, people would have elective deliveries, because we just, it was like, it's the week before Christmas and my doctor promised I would have my baby for Christmas, so I'm having my baby. And that was the kind of things my husband would see. And back in the days of the father's room, that was the kind of things he was hearing in the father's room. And he was like devastated because we were fighting with every inch of our life to keep my pregnancy. So this is real life world. And this is maternal health. And this is the kind of things we need to protect against.
Thank you, Rosie. And it's a good point about the potential for a backslide if the measure were to be discontinued. So thank you for raising that. Christina.
Hi, so speaking to the second question of leaving a gap in the program related to maternity care, it did seem like with the OBGYN and the nurse midwife, there are a substantial number of other measures that they can choose from. So I am not concerned as much about the gap. Going back to what Ron Klein said, though, about would getting rid of this measure have an impact? anecdotally in my work, there are measures where they really are just measuring, and then there are others that seem like they're key players in the work itself. And anecdotally, I do hear more talk in my role in quality of people saying they're not going to do it because they're getting measured with this particular piece. And so I do have some concerns with elimination without monitoring plan for this measure because of how frequently I hear that sentiment.
Again, I just want to clarify that this is for the MIPS program and the clinicians select this measure. The comment, I think the top comment about it being topped out is confusing because the commenter asked, is this the same measure? And they referenced the CMS hospital program and the Joint Commission measure. And as the Joint Commission said, it is not the same. So the comment about it being topped out and removing this measure does not apply. There's insufficient data for this measure, and that's why we proposed the changes for it to remain in the MIPS program. I just wanted to clarify that.
Yep, Marcia, thanks. That was, I think, the same clarification that Michelle Dardis from the Joint Commission brought up, which is that it looks like the measure that the public commenter was referencing was a different measure that looked at a slightly different population. And so yeah, you're correct. That's not relevant to this discussion. So the topping out piece shouldn't factor into this discussion, but I don't think that undermines any of the other comments that we've gotten so far related to the role of this measure in the program. Thank you. Akeem, go ahead.
So Michelle's comment takes me in a slightly different direction, and that is, I do wonder whether having this measure in the MIPS program versus the new cesarean birth ECQM that's in the IQR may be potentially setting up some inconsistent measurement approaches between the clinician programs and the hospital programs. And I would be curious, is that something CMS has looked at? And is the agency considering a version of the hospital measure for clinicians? It would be useful to understand kind of where that may go.
I'm not sure I understand the question. Can you try that one more time?
So leaving aside the question about whether this measure is topped out, which was referring to the old IQR version of the measure, which has been retired from the IQR program. The current IQR program includes a cesarean birth ECQM. And so I'm wondering, does continuing to use this early elective delivery measure in the MIPS while having a cesarean birth ECQM with slightly different specifications in the IQR, are we creating inconsistent incentives across the programs and inconsistent measurement approaches? I'm not sure I know the answer to that question, but I would encourage CMS to explore it a little bit.
I may be missing the point here, but I mean, yes, when you get into the weeds into how you define everything, we try to align, but we're not always successful. But one measure talks about an early elective delivery before 39 weeks, which you're delivering a premature baby that modern technology, generally is likely going to do well. And the other's talking about a cesarean section rate. So they're two different things, which is why I'm not sure I'm following your question.
They are separate, but they are potentially related to that. That's why as I said, I don't have the answer to this question, but it just makes me wonder about creating consistency across programs. That's all.
It sounds like an alignment question, right? Akeem, the idea of sort of just trying to align across programs to limit reporting burden for facilities that might, right? Is that the question?
I mean, we can always do better at that. If a woman is delivered at 39 weeks in a day, will not will not count for this measure in the numerator, but has a cesarean section, and she will. So I guess that's why I'm struggling with they're really one is measuring early delivery, the other is measuring a C-section rate. So yes, agree. How you define your numerators and denominators. That's always tricky and always we can prepare to discuss that. But the actual action, the theory of action, if you will, these two measures is very different. That's why I'm struggling with the question. But we can move on. I just wasn't sure I followed because again, they seem like different things.
Did you have any follow-ups, Akin?
I don't. It's probably a longer conversation to take offline. I'm just cognizant of how much work is going into improving maternal outcomes. And I just want to make sure that everything that we're doing across these measurement programs is pointing everybody in the same direction. It may be, Dr. Klein, that the basis of the measures is different enough that there is a good reason to continue to have this measure in the MIPS program. But I just want to make it explicit that it's something we have to be really attentive to. It's so important we get this right.
Understood. Thank you for the comment. Corinne, go ahead.
Just echoing what Akin said, my hunch, knowing how this measure is reliant on information that is stored in the hospital medical record, and then how you package it and transmit it to CMS. By having a similar measure that's looking at different, you could say, data points, it will be more difficult and more burdensome if an OB chooses to report on this measure to be able to package and transmit the data to CMS. And less likely when you have a conversation with the hospital administrator, willingness to, as a team, to agree to this measure. Their efforts will be focused on the hospital measure. It's just the nature of how things work. There's multiple programs, various impacts. It's probably also a reason why this measure is not being reported on. You're reliant on the hospital to obtain that information, and it's extremely challenging for numerous reasons to be able to appropriately package and submit that information to CMS on the physician side.
Thanks for that clarification, Corinne. Go ahead, Michelle.
Thanks. I wanted to respond to Akin's comment and question because I think it was a good one. And I want to respond as the Joint Commission and not the use of the measure in the IQR program. We have stopped using the hospital version of this measure in our hospital accreditation program. It used to be a required measure, and we have retired it in our hospital accreditation program. We continue to use it in our perinatal care certification program because we do think it's an important indicator of quality, if not an accountability measure at this point. Within our hospital accreditation program, we do think of the cesarean birth measure and the severe maternal morbidity measure as more proximal outcomes than PCO1. And so looking at the measure performance and the other available measures led to our decision to remove that measure from accreditation. So that's in response to Akin and specifically the Joint Commission view. I don't mean to speak for CMS.
That's really helpful context. Thank you. Akin, any follow-ups there? Okay.
No, sorry.
No, thank you. It prompted a good conversation. So I think it's probably time for me to go ahead. Yeah, I see Rosie shaking her head. Good. Okay, so good discussion here, a little bit more back and forth. So bear with me here and please do chime in if you feel like I've missed an important or salient point for voting. But what we heard in general is that although this measure wouldn't necessarily leave a gap in the programs, what we have learned is that this measure is used in many different specialty sets, meaning that it's cross-cutting and signals an important topic within CMS. It's a high priority area for CMS, especially in light of the maternal health crisis. We heard from Jennifer that this is especially important in rural settings and to keep in mind the overall context in which this work is occurring. We heard from both Rosie and Christina that this measure is highly actionable. From Rosie's perspective, there were lots of concerns that removal of this measure would almost certainly lead to a backslide in performance, seeing more elective deliveries before 39 weeks. And Christina pointed out that this seems like one of the measures where it really does seem to impact care, that providers are behaving a certain way because they know they are being measured here. Akin raised some concerns around, just in general, around alignment, making sure that the measures used in the MIPS program align with those used in the hospital program as a way of responding to reporting burden for those entities. And we heard that the Joint Commission is keeping the same sorts of things in mind. And Michelle gave us some context for how the Joint Commission is using this and other measures across their different programs. Did I miss anything? Is there anything anybody would like me to raise before we take this to a vote? Okay.
You did a good job.
Oh, go ahead.
I think you did a good job.
Thank you. All right, Isaac, let's take this to a vote.
Voting is now open for the measure on maternity care, elective delivery without medical indication at less than 39 weeks overuse. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, and B, no, discontinue use. And we're expecting 24 votes. We're waiting for one more vote. We have all 24 votes. Voting is now closed. We have 18 votes for continued use and 6 votes for discontinued use. With 75% voting for continued use, the committee recommends the continued use of this measure in the merit-based incentive payment system.
Thank you, everyone, and thank you, Isaac. All right, we are moving right along here. So let us jump to the next slide on the emergency department measures. So you'll see we have 2 measures listed here. So let me just give you kind of a summary on how this part of the discussion is going to go. So these are, they're essentially the same measure, but they are specified for 2 different age groups. So we are looking at emergency department utilization of CT for minor blunt head trauma. The first measure, which is 23702, is for patients aged 2 through 17. And the other measure, which is 237-01, is for patients aged 18 and over. Because the measures are so similar, we are going to have the discussion all together. I will do my best as I'm explaining the public comments to distinguish between anything that's unique to one or the other. We'll go through the discussion at the same time, and then at the end, we'll have 2 separate votes, one for each age group measure. So if anybody needs clarification on that or a reminder as we go along, let us know, and I'll remind you again before we get to the voting piece. But with that, let's go to the next slide here. So these measures are looking at the percentage of emergency department visits for patients who presented with a minor blunt head trauma, who had a head CT for trauma ordered by an emergency care provider, and who were classified as low risk according to the prediction rules for traumatic brain injury. And this both were stewarded by the American College of Emergency Physicians. It's used in MIPS. They are process measures at the clinician level of analysis. They are not endorsed, but they are collected as part of normal clinical workflows, and neither one satisfies a statutory requirement. So with that, I would like to turn it to Dr. Klein to give us the CMS perspective on these measures. And Ron, if you're speaking, you are muted.
Sorry, I had to unmute myself. The dreaded, there we
No
go.
worries. Go ahead.
All righty, so let's try this one again. So hello again. CMS recommends maintaining both the efficiency measures as they address the CMS high priority for patient safety, which ensures that patients are appropriately selected for CT to minimize both radiation exposure and cost of care. And I would just mention as a pediatric hematologist oncologist that one of the things we're finding, unfortunately, is that even a relatively small number of CT scans to the head or CT scans to the body is resulting in measurable increases in cancer. So this is an important issue. Both measures are included in the emergency medicine specialty set and the adopting best practice in promoting patient safety within emergency medicine MIPS value pathway. For measure 237-02, which is the one pertaining to 8 patients aged 2 through 17, the 2024 historical benchmark for this inverse measure has a performance rate of 5.92%, which indicates a continued gap in performance. For measure 237-01, which is pertaining to patients 18 and older, the 2024 historical benchmark has a performance rate of 97.7%, so this is when it's not an inverse measure. So, and this measure is the second year of the top-out life cycle, with a measure. However, with a measure included in the MVP, there may be increased adoption of the reporting measure, which may further establish a gap in performance. So what we're trying to say there, and this sort of all is sort of the issue we've sort of been talking about sort of directly and indirectly, you know, since this morning, which is when people pick their own measures, they're likely to pick the measures they're going to do better on. That's just normal human nature. But the question we have is, now that we've incorporated this CT scan, you know, with blunt head trauma into a larger emergency medicine measure set, some people will pick that measure who might not otherwise have chosen it, and therefore will we see a larger gap in the future within the MVP that we're not seeing now. So hopefully I said that clearly, and I'm ready to turn it back over for discussion.
Thank you very much. Let's go to the next slide. So for these two measures, we received one overall public comment that applied mostly to both measures, stating that they are widely used among MIPS participants, and indicated that even despite selective reporting, that the child measure is not at all topped out, and that the inclusion of these measures in the emergency medicine MVP suggests that they are valuable to CMS, which is, I think, also reflected in Dr. Klein's remarks. The PI-form feedback overall indicated support in terms of the reduction of overuse of imaging. When it came to the pediatric measure, the support really came from an acknowledged need to reduce exposure to radiation, especially for pediatric populations, given the potential for increased lifetime exposure. For the adult measure, the benefits from the PI-forms were mostly related to reducing overuse and reducing cost. From a patient journey perspective across the board, reviewers felt that it aligned with patient perspectives, that the appropriate use of scans is important, and also addresses concerns around ED overcrowding, limited access to CT resources, and then overall radiation exposure. And from a data stream perspective, folks felt that this was relatively low burden compared to the overall benefits of the measures. Let's jump to the next slide, please. So when we get to the discussion slide, sorry, we go to the next one. I just summarized both in the same thing. Yeah, there we go. You know, overall, there has been agreement that the overuse of imaging is a patient safety issue. So reducing it in the emergency department is a meaningful thing to measure. In terms of concerns, you know, the PEDS measure, the concerns were about instances where the benefits of imaging may outweigh the added radiological risk, whereas for the adult measure, there were just concerns that the measure might limit patient-centeredness by disincentivizing shared decision-making, which is a conversation that we had earlier with the incidental findings measures. So I think we can kind of start wherever folks would like to. These two discussion questions are here just to get you started. Obviously, Dr. Klein already addressed the issue of being topped out, just indicating that that's really has to do with the voluntary reporting. Christine, I see your question in the chat, so I think this is probably for CMS or the measure developer. Can you talk about how variations in, or whether there are variations in how minor blunt head trauma is documented?
I'm going to leave that to the measure developer, but before I do that, I wanted to jump in real quickly, since I do work in a pediatric ER a couple times a month. is that there are very definite criteria for head injuries in pediatric patients. They're called the PCARN criteria, PECARN. So it's not really a subjective issue. There's been a cooperative group that's come up with criteria. So it's very, very definite for the pediatric world. I'll leave the adult world to this measure steward.
This is Lisa Marie. I don't know if we have anyone from ASIP on the line. I was looking through the
I'm here.
names, so. Okay, great. Thank you.
Hi, everyone. This is Michelle Lynn. I'm an emergency physician, and I oversee quality measure development on behalf of the American College of Emergency Physicians. Thanks for bringing these two measures for discussion and for some of the context, Dr. Klein. We agree that both of these measures should be retained. From our perspective, there just isn't sufficient data at this point to conclude that they're topped out. First of all, because of the addition to the MIPS value pathway and because of the multiple years of exemption due to the COVID emergency, which heavily impacted our specialty. We expect many more emergency physician groups to be participating in 2024. So we anticipate that will contribute to more accurate data on actual performance. So we think both of these measures are very important to retain for that reason. A second point is that it would actually leave a gap in the MIPS program. We previously had a separate digital quality measure through our qualified clinical data registry that was deemed to be overlapping with this QPP measure, and we therefore retired it just last year. So at this point, these two are the only measures looking at minimizing the use of head CT in minor head injury. And as it's been mentioned before, the use of ionizing radiation continues to increase about 3% per year, with a 10 to 15% increase over the last decade. So it is continuing to be a problem overall, and we do believe that it's a priority from a patient safety perspective. So those are the questions, I think, pertaining to the first one. Pertaining to the second question, and Dr. Klein also alluded to this to some extent, but the evidence base for pediatric measures and adult measures are completely separate. So there are separate bodies of evidence that have derived definitions for minor blunt head injury and criteria for who is most likely to benefit from a CT. And these are done in under 18 populations and over 18 populations. So the criteria and the decision rules used in everyday decision-making are different. The PCARN one is the most commonly used one in the pediatric population, and that's the one that Dr. Klein mentioned. And in the adult population, there are decision rules such as the Canadian Head CT rule, the NextSet CT rule, and those are not validated for use in adult patients. So the evidence base is different. Second of all, the imaging uses rates are totally different. So, in general, we are cognizant of the magnitude of the impact of ionizing radiation in pediatric populations. So we certainly make an effort to minimize that. Therefore, in general, the use of CT is much less prevalent among those in pediatric populations. So if we were to combine these measures for whatever reason, it would not be an apples to apples comparison. And then lastly, of course, the impact of ionizing radiation is much higher in pediatric populations relative to adults. So for all of those reasons, we would strongly urge you to retain these measures so that there isn't a gap in the portfolio, and to keep these measures separate because of the evidence base and the way that these are used. Thank you.
Thanks. So, Michelle, would you mind just speaking to Christine's question in the chat, which is whether there are variations in how minor blunt head trauma is documented in the EHR?
I can't see the chat. I apologize. There are definitions for minor blunt head injury. So there may be a minor amount of variation, but for the most part, no. When these decision rules are being applied, there are specifications with respect to whether or not there is loss of consciousness, what type of mechanism was involved. So I think that there is a reasonable agreement among the majority of practicing emergency physicians what would qualify as minor blunt injury.
Thank you. So we've heard a lot from CMS and from the measure developer on the potential advantages of retaining both of these measures and keeping them separate. I'm interested in the committee's perspective here, whether you agree or if you have any concerns that you'd like to talk through before we vote. I saw Christine commented in the chat that she has no concerns. Go ahead, David.
I think this is very straightforward as far as the patient perspective is.
In the positive or in the negative?
Positive.
Okay, thank you. Yeah, David, go ahead. Oh, you're muted, David.
Very supportive as an emergency medicine physician. I am good with both the pediatric and adult. And the criteria is pretty clear as a practicing physician how to apply these.
Okay. Anyone else? Okay. Well, hearing none, I did want to make sure that I am keeping us moving. Mark, I see your comment in the chat. As a head injury survivor, I could have used a CT at the time of my injury. So hearing the importance of making sure that those for whom it's indicated do receive that imaging. Appreciate that. Thank you for sharing. All right, so what we've heard across the board is that from a CMS and measure developer perspective, these measures represent an important aspect of care. There are very strong and clear guidelines, especially in the pediatric context upon which these measures are based. And we've heard support from both the clinician perspective from Rosie and from the from the patient perspective from Rosie and from the clinician perspective from David Levine, overall support for these measures. We did hear Mark's concern in the chat, just cautioning against weeding out too many patients that might not receive it. But otherwise, I didn't hear any comments against retaining the measure. Before we take it to a vote, I'm just going to wait 10 seconds to see if anybody else has any comments. All right. You better bet I counted those Mississippis in my head. Okay, so Isaac, let's take this to a vote.
Voting is now open for the measure on emergency medicine, emergency department utilization of CT for minor blunt head trauma for patients aged 2 through 17 years. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, or B, no, discontinue use. And we are expecting 24 votes.
And as a reminder, we're going to be doing 2 votes. So this is for the pediatric measure. We will vote separately on the adult measure.
Correction, we're expecting 23 votes. We're waiting for one more vote. All right, we have all 23 votes. Voting is now closed. We have 23 votes for continued use and 0 votes for discontinued use. With greater than 50% voting for continued use, the committee recommends the continued use of this measure in MIPS.
Thank you, Isaac. Let's jump to the adult measure now.
Voting is now open for the measure on emergency medicine, emergency department utilization of CT for minor blunt head trauma for patients aged 18 years and older. Do you recommend the continued use of this measure in MIPS? The options are A, yes, continue use, or B, no, discontinue use. Waiting for 3 more votes. One more. We have 23 votes. Voting is now closed. We have 23 votes for continued use and 0 for discontinued use. With greater than 50% voting for continued use, the committee recommends the continued use of this measure in MIPS.
Thank you, everyone. Thank you, Isaac. Okay. I'm just pulling up our agenda here. And we are, believe it or not, ahead of schedule. So before we had originally planned to just jump into our next block of measures, but I think it makes sense for us to take a little break. So how about we come back at 2:45? So everybody just take 15 minutes, get a little water, get a little tea, and we'll see you back here at 2:45. Thanks, everyone.
So we can move to the next slide. Great. Okay, so we're continuing with our appropriate use measures here. This one is the percentage of patients who died from cancer receiving chemotherapy in the last 14 days of life, where lower score is better. And this is measure 005431 in MIPS. So I think we can move to the next slide. So the brief description of this measure is the percentage of patients who died from cancer receiving systemic cancer-directed therapy in the last 14 days of life. The measure steward is the American Society of Clinical Oncology, and it is used in the MIPS program. It is a process measure at the clinician level of analysis. It is currently endorsed, most recently in spring 2022. All required data are collected as part of the clinical workflow, and it does not meet a statutorily required category area. So with that, I will turn it over to Ron Klein for the CMS perspective and background on this measure. Let me see if Ron, if you're talking.
Yep, I'm there. Sorry.
Oh, great.
I have to take myself off of mute again and on video. So CMS recommends maintaining this inverse appropriate use measure as it addresses a CMS priority of appropriate use of healthcare for cancer patients in the last 14 days of life. The measure is applicable to oncology clinicians, and as a result, the measure is included in 2 specialty sets as well as the Advancing Cancer Care MIPS Value Pathway. Also, the measure is part of the Core Quality Measures Collaborative measure set, facilitating alignment across programs. The 2024 historical benchmark for the measure indicates a gap in performance at 10.71%. The measure performance has shown improvement based on the historical benchmarks, with improvement from 14% for the 2021 historical benchmark to 12.45% for 2023. And as I mentioned, for 2024, it's 10.71%. So it's doing what we always hope a measure will do, which is to drive improvement. And I would say, just as a pediatric oncologist, hematologist oncologist, the subjective part of this measure is, as much as we wish we could cure every human being of cancer, we can't. And so at some point you have to say, we've done as much as we can. Let's make your quality of life the very best it can be. Let's give you the best quality life we can for as long as it lasts. And getting chemotherapy until the very, very last moment of death is really not the right thing to do for most patients. And again, that's a decision of both the physician and the patient, but it requires difficult conversations. So that's what this measure is about. And with that, I'll leave it open for discussion.
Thank you, Ron. I think we can move to the next slide. So just to summarize the PI feedback and public comment, we had 2 committee members respond to the pre-meeting initial evaluation on this measure, all supportive, saying that the measure did meet the 3 evaluation criteria of meaningfulness, patient journey, and data stream parsimony. Of note, the patient journey supportive comment notes that caregiver perspective values this measure for improving quality of end-of-life care and promoting patient voice in decision-making. We did receive 2 public comments. 2 were supportive and no concerns raised. One of the public comments containing 3 arguments outlined here are from the measure developer and the measure steward. There was support for retention of this measure because patients undergoing chemotherapy are underserved in terms of symptom management and end-of-life care. The measure steward noted that the measure is actionable, impactful, and not duplicative within MIPS. The measure helps to ensure patients and their families are making informed decisions about end-of-life care, and it can help identify providers that are pushing overly aggressive chemotherapy at the end of life. So we can move to our discussion questions. As we've just seen from the pre-meeting initial evaluation forms, committee feedback was largely supportive. Are there any concerns about this measure from the committee? And just from an equity perspective, are there any patient groups or subpopulations that are more likely to be impacted by this measure in terms of its benefits or harms than others? So you're welcome to start there or anywhere else you'd like to comment as we resume conversation. Yes, Corinne.
Yeah, we support retaining the measure, but I just want to highlight that there's an error in the measure title. And it's I think it was also done when it was originally placed on the MSR list. It's percentage of patients who died from cancer receiving systemic cancer-directed therapy in the last 14 days of life. It's not just restricted to chemotherapy. So I think that's worth noting, because if people don't, potentially the full don't review the full specifications, there could be some misunderstanding, and we support maintaining the measure in the program.
Just if we wouldn't mind hearing from CMS or the steward on the correct title, that would be helpful.
This is Lisa Marie. Corinne is correct. The title is what she had referenced. It's the percentage of patients who died from cancer receiving systemic cancer-directed therapy in the last 14 days of life. That's the correct title.
And I think, just to get into the weeds here, I think the idea here is that as our tools to treat cancer have expanded, there are things other than chemotherapy that we use, like immunotherapy and as well. And then I think the argument about systemic therapy is it means that we can capture it in Part B as in boy claims, as opposed to oral chemotherapy, which would require Part D as in dog claims as well.
Great. It's an important clarification. Thank you. So aside from that, the modification to the title and what's captured there, are there any concerns about this measure that anyone wanted to raise? Corinne, is your hand up from your previous comment? Or did you have something to add?
Oh, yeah, sorry.
Oh, no worries. Rosie.
Well, I guess I had my husband died in 2020 very suddenly from misdiagnosis or a late diagnosis of cancer. And by the time he was diagnosed, he was given a very short time of living. And then they offered him what they called comfort chemo. And because he was in so much pain, he took the comfort chemo, and but they hadn't told him everything that the comfort chemo could have. What, they said it could go one of two ways, but they didn't tell him that the comfort chemo might create more pain than he already had. And then within 8 days of that one dose of comfort chemo, he died. And it wasn't like, but so I really, this really touched home to me, because and I was the person that was one of the people that responded to this. But it really is important to keep this and to not ever let it go away, because it's important to the families and to the patients, and not only explanation, not only having this, but also some education about what kind of chemotherapy and different types of therapies and what the results could be, because he probably would have been better off going on hospice rather than, eventually, the last day of his life, I got him on hospice, but it was too late, too little, too late.
Yeah, thank you, Rosie, for that powerful story. I think that your comments are highlighting the importance of that education piece to support shared decision making. So really appreciate you telling that story. Any other additions or reflections we want to share on this measure? I'm seeing no concerns from several committee members in the chat. So I think we can move to the vote on this one. Not hearing any concerns raised. I'm looking at Rosie and Akeem. You feel comfortable with the vote? Okay.
Yes.
So Isaac, let's turn it over to you. And I think Mark Paris has put his vote in the chat.
Voting is now open on the measure for percentage of patients who died from cancer receiving systemic cancer-directed therapy in the last 14 days of life. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, or B, no, discontinue use. And we're expecting 23 votes. All right, we have all 23 votes. Voting is now closed. We have 23 votes for continued use and 0 for discontinued use. With greater than 50% voting for continued use, the committee recommends the continued use of this measure in MIPS.
Great. Thank you, everyone. And especially thank you to Rosie. We're seeing a lot of gratitude for your advocacy and your participation in these processes in the chat, and for sharing your story. So thank you. Okay. Let us move forward to the next measure. This is unplanned reoperation within the 30-day post-operative period. This is measure 0073701 in MIPS. And we can move to the next slide. So just the brief description of this measure. This is the percentage of patients aged 18 years and older who had any unplanned reoperation within the 30-day post-operative period. The measure steward is the American College of Surgeons, and it is used in MIPS. This is an outcome measure at the clinician level of analysis. It is not endorsed and has never been endorsed. All data are collected as part of the clinical workflow for this measure, and it does not address a statutorily required category. So I think with that, I will turn it to Dr. Stephanie Clark to present the CMS perspective on this measure.
Thank you, Meredith, and good afternoon again, everyone. This is an inverse outcome measure that is included in 3 MIPS specialty sets. The purpose of the measure is to capture an important adverse surgical outcome and improve the quality of surgical care. The measure does align with CMS's priority to move towards outcome-based quality measurement and is applicable to many clinicians. There is an ongoing collaboration with the measure's steward to broaden the denominator to include coding for additional specialties, which may increase the adoption of the measure and establish a wider performance gap. In the calendar year 2025 physician fee schedule proposed rule, we propose substantive changes to the measure updates, including revisions to the denominator criteria and coding for fissurectomy, including sphincterotomy, as such procedures could have complications requiring unplanned reoperation within 30 days. This measure is similar to the failure to rescue measure within the hospital program, facilitating alignment between programs, which we really do strive for where possible. I'll also note that while this inverse measure is high performing with a payment year 2024 historical benchmark at 1.59%, it is not topped out. The measure was finalized for inclusion in the otolaryngology focused MIPS value pathway and is proposed for inclusion in the surgical care MVP in the calendar year 2025 proposed rule. And also of note, the measure performance has shown year-over-year improvement per the historical benchmarks. And I will pass it back to you, Meredith, for discussion. Thank you.
Great, thank you. So we can move forward. In terms of pre-meeting initial evaluations, we received 2, and they were unanimously supportive of the meeting of the meaningfulness criterion. The measure relates to patient safety. In terms of the patient journey, this criterion was also met. It aligns with the patient journey within the 30 days post-surgical procedure, and patient perspectives that were provided in the forms indicate that the measure is valued and should continue in the program. And then in terms of data stream parsimony, committee members noted that there was low data collection and reporting burden, and we did not receive any public comments on this measure. So we can move to the next slide. So just reflecting on what we just saw, initial committee feedback was very supportive, wanting to surface any concerns people might have about this measure here. And just something for the patients to reflect on is how does this measure align with the patient journey or reflect patient perspective. So again, you're free to comment on other aspects of this measure. This is just some thoughts to get us started. Akeem, yes.
This is more of a kind of a measure mechanics question. This focuses on unplanned reoperations. Could you talk just a little bit about how that definition of unplanned is constructed? You don't have to get too into the weeds into it, but just some basics would be helpful.
Do we have the measure steward on the line for this measure? Anyone from the American College of... Oh, go ahead.
Yeah, I was just seeing if Tyler or Erica are on the line.
This is Erica, sorry. Took me a minute. So the way that it is set up, it is a code for unplanned. So this is, if there is a plan based on the codes, then it would not be utilized for this.
It's a little hard to hear you.
No.
You're breaking up.
Sorry. Can you hear me now? Is that better? Okay, sorry. So the way that this is set up, it is obviously the inverse measure. So if it is coded as unplanned or if there's a non-clinical reason that was expected, then it gets pulled out. And part of it could be self-report. Or if it was, sorry, I had 2 different in front of me. we pull out for telehealth. Otherwise, if it's an unplanned readmission or reoperation, it gets pulled in.
Got it.
And it uses the ICD procedure codes in that. Do you
Got
need
it.
the specific ones?
No. I was just, I was trying to remind myself of why a measure like this would not have risk adjustment. And what came to mind was there's something in how unplanned is getting coded that may try to account for that. So you answered my question. I really appreciate it.
Great. Thanks for that question and the clarification. Do any committee members have questions? Sai, I see you have your hand up.
Yeah, I think I heard that this measure is used for 3 specialties or 3 surgery types. Can you provide a little bit details here?
Lisa Marie, do you want to take that?
Can you repeat the question relative to what you're asking with like risk adjustment? Sorry.
No, it's not about risk adjustment. I think when you introduce the measure, someone mentioned how is this measure used for which specialties. Do you have any?
Yes, you had mentioned that it was in 3 specialty sets, but every
so
physician could choose it, right?
Yeah, so the measure is in 3 specialty sets: general surgery, which there's 13, plastic surgery, which there's 9, and ophthalmology, which is 22 measures in that. It's also in the quality care for treatment of ear, nose, and throat disorders, MVP, and it's proposed for the surgical care MVP.
Thank you.
Thank you for that information.
Can I just say that in terms of when we report this measure to our programs, we do actually use risk adjustment. And I think there is probably, if you could promote some of our other team members to, I don't know that everyone is panelists as well. So Jill Sage is also on.
So we're looking to promote Jill Sage.
Oh, yes. Can everyone hear me?
Yes.
Yeah. So some of these, this was one of the measures that we had originally created when we had set up the surgeon-specific registry as a MIPS registry many, many years ago. And we tried to submit this as well as the other surgical outcome measures with a risk adjustment algorithm, but CMS wasn't able to implement it at that time. So, I mean, we've always expressed our concerns about the lack of risk adjustment for the readmission measure as well. I mean, generally speaking, the sort of the rigor behind a lot of these outcome measures, especially within the MIPS program, you know, there's a lot of just concern regarding the fact that these are surgeon specifics measures, and they sort of look across a broad spectrum of procedures, and you're not risk adjusting with a single source if you're risk adjusting across all these sort of different registries in a silo. So these, you know, we've raised these concerns over the years with our comments about these measures, but so just wanted to add that.
Thank you for that background. Christine, I see you have your hand raised.
Yeah, sorry, I couldn't find the mute. So I had a surgery a few years ago, and about not even less than a month after the surgery, it was a few weeks afterwards, I had to have a repeat surgery because it was handled wrong when I went to a different appointment. And so I totally support this measure on the following this, and then having patient education in order for them to really communicate with their physicians and looking at this holistically instead of just as a surgery for one area and not considering it at the future appointments. If that made sense at all. Sorry.
No, thank you for that. I think, you raised the question about education and shared decision making, which is important quality improvement strategy for many of these measures. So thank you for raising that. I see there was a question in the chat, Sai asking for information about which measures are used for which specialties in MIPS, and Lisa Marie is going to provide a link to that information shortly. So stay tuned there. Are we ready to vote? Has anyone expressed it? Does anyone have any additional concerns to express about this measure? No, I'm seeing some head shaking. No. Rosie and Akeen, do you feel comfortable with moving to a vote?
Yes.
Okay. Isaac, let's go ahead.
Commissioner will show up shortly. Voting is now open for the measure on unplanned reoperation within the 30-day post-operative period. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continue use, or B, no, discontinue use. And we're expecting 22 votes. We have all 22 votes. Voting is now closed. We have 21 votes for continued use and 1 vote for discontinued use. With greater than 50% voting for continued use, the committee recommends the continued use of this measure in MIPS.
Okay, thank you, Isaac. Thanks all for that discussion and vote. We're going to move to the next measure, which is on a similar theme. This one is unplanned hospital readmissions within 30 days of principal procedure. So we can move to the next slide. This is the percentage of patients aged 18 years and older who had an unplanned hospital readmission within 30 days of the principal procedure. Again, this is an American College of Surgeons measure, stewarded measure. It is in use in MIPS. It's an outcome measure at the clinician level. It is not endorsed and has not been endorsed, but all required data are collected as part of the clinical workflow, and it does not address a statutorily required category. And with that, I will turn it back to Stephanie Clark.
Thanks, Meredith. And so this measure is similar, and so many of the comments from especially the measure steward will apply to this measure. This is an inverse outcome measure that is included in 3 MIPS specialty sets, the same specialty sets that were discussed before. And the purpose of the measure is to capture an important adverse surgical outcome and again, improve the quality of surgical care and the follow-up. This measure aligns with the CMS's priority to again move towards outcome-based quality measurement and is broadly applicable to many clinicians. It's also similar to the failure to rescue measure that we discussed in the previous intro within the hospital program, facilitating alignment. While this inverse measure is high performing, it is not topped out with a payment year 2024 historical benchmark at 1.97%. There may be potential for future use of this measure in the surgical care MIPS value pathways, which would increase the adoption of the measure and establish a wider performance gap. Performance for this measure has shown gradual improvement based on historical benchmarks. And I will send it back to you, Meredith, for discussion.
Thank you. Let's move to the next slide. So you can see on the left here, the pre-meeting initial evaluations that we received were largely supportive of this measure in terms of meaningfulness, in terms of patient care journey and data stream parsimony. Committee members noted in terms of meaningfulness that it's important to patient safety and in reducing healthcare costs, and that the measure is feasible. In terms of the patient care journey, committee members commented that the focus on patient safety during the 30-day period aligns with the patient perspective and journey, and it's of value to our patient respondents. And in terms of data stream parsimony, committee members noted low data collection and reporting burden, and we did not receive any public comments on this measure. So we can move to the next slide, which just has a couple of thought questions. Seeing the positive pre-meeting initial evaluations from our committee members was largely supportive. Do others have any concerns about this measure? And just for consideration, what are potential unintended consequences for continuation of this or other readmissions measures? Some things might be penalization of entities treating low income or minority patients, or lack of connection between the reason for hospitalization and the index procedure. There might be other things that come to mind, but I will open it up for the committee. David Levine, yes.
Yeah, a couple questions because I didn't have a chance to pull up the exact specifications of the measure. First of all, just reiterate, I'm guessing this is not risk adjusted, since it's just a percentage measure. And then second, it's all unplanned readmission, so it does not have to per se be related to the procedure, that one could come back from something that may not be related to the procedure as long as it's not planned to be counted.
Let's turn to the steward for those questions. Do we still have?
Erica or Jill, are you able to address the question?
Yes, so you are correct that it could be some other readmission outside of, there is a modifier for if it's a telehealth that does not go in.
And then also no adjustments.
No risk. I'm sorry.
And no adjustments for social determinants of health at all.
No, this is just a straight, similar to our comments previously when it was originally submitted, we did have risk adjustment, and when we, outside of like a straight benchmark, we risk adjust in our hospital-based measures for this. Because there are a multitude of reasons, multiple different types of surgeries that this could be used for.
Yeah, I mean, so my overall comment, like unlike the previous measure, which I thought was a great measure because it's very much related to the procedure and a repeat procedure, this now gets to messiness of a lot of reasons why someone like revisits and gets readmitted to the hospital, from not being risk adjusted to social determinants of health and unrelated procedures. I think we'll get into a lot of this with 30-day readmissions period, the end with, I think, probably the bulk of tomorrow. This, especially holding it against the individual surgeon or clinician, I just have a lot of problems with. I would not support this because of the things that are missing here. I really appreciate the attempted approach to have the risk adjustment originally. Really sad that that wasn't accepted.
Thank you for that. Thank you for asking your clarifying questions and then reflecting on the answers. I see other folks nodding as you were making your comments. Corinne, I think you are next with your hand up.
Yeah, thank you. There is also another all-cause readmission. There are other readmission measures in the program that CMS will attribute. It's not by choice. It's an administrative claims measure. Other administrative claims measures. So if you meet the attribution, you will get tagged with the measures. How come the other readmission measures were not included in this evaluation? Would be helpful to understand. And then also, what are the differences between the CMS admin claims readmission measures and then the College of Surgeons measures? Because even if we let's say we recommend removal of this, there's still other readmission measures in the MIPS program that you get tagged with regardless, or you could now get, if you report on this measure, because it's in an MVP, you still are subject to the all-cause readmission measure, because that's considered a foundational layer measure. CMS created an additional category for MVP.
So I think those sound like questions that may be best addressed from CMS, how this measure is related to the other readmission measures within MIPS, or how is it unique?
I mean, I'll jump in, and certainly other folks from CMS, who or measure stewards know this measure better can do that. And I think part of it is you're limited to what you can do when you look at things from a claim standpoint. And there are so many different ICD-10 codes that it's sort of, a person may come in because of a surgical complication, or and it gets coded differently, and all of a sudden you don't capture that. So I think it's an imperfect measure in that sense. But I think that is the nature of what we can do. I know that I worked on the oncology care model for a long time, and it was a total cost of care measure. And the reason we did that is because it was so difficult, because cancer was so complicated and surgery is so complicated, that it was really impossible to determine what was, cancer related if the person chose to try to, confuse that measure. So I think that's probably not the best answer in the world, but it's basically the nature of making things work. And I think when medical records get, EHRs get better, or when claims get better, or when whatever gets better, we'll be able to have more nuance there. But I think that's really the nature of the beast right now.
And then is this clarification in terms of why weren't we asked in conjunction to review the other MIPS readmission measures?
I can't speak to that.
Or rate, in parallel, so we get the full picture.
And we have administrative claims measure that's readmissions, but I'd have to look to see our entire inventory. I mean, we have like 190 some measures in MIPS, and then we have TCR measures. I'd have to go back just to see, how they would compare, but I don't have that analysis on me at this moment. I'm not able to provide further information.
Meredith,
but I'm just gonna research it right now and get back to you, but I will try to get to you before a vote. I don't know how long the conversation will continue, but I will work on that on this request.
Okay.
And Meredith, I was just going to say, if you all from a process perspective have a reason, that this specific measure was chosen as opposed to any of the other readmission measures, that might be helpful.
Yeah, I will actually have to take a look. I don't know if anyone from my team has that answer readily available, but we will also do our due diligence to get an answer on that. In the meantime, Michelle, I think you have your hand up.
Thanks. Yes, I wanted to make sure I heard the MIPS historical benchmark correctly. Was it 1.7%? And we were asserting that that's not topped out. If so, I'm questioning how we define topped out, because I think earlier we discussed a measure where the performance score, also an inverse measure, was below 4%. It was the appropriate follow-up imaging for incidental thyroid nodules measure where the rate was 3.73%. We said that was topped out. So I'm just questioning how we're approaching the topped out designation.
So I just want to note that there's topped out definition for a non-process measure that's different than a process measure. For this measure, it's a non-process topped out measure, which means a measure where the truncated coefficient or variation is less than 0.10 and the 75th and 90th percentiles are within 2 standard deviations. That's the definition for a topped out non-process measure, which is what this measure is.
Thanks, that helps. I guess personally, because it's not risk adjusted, I'm still questioning the validity, I guess, of calling this not topped out when the performance rate is so low.
Thank you for that, and thank you for clarifying the differences in the topped out definition. Devika, you have your hand up.
Yeah, I will say David really took a lot of the words out of my mouth. I think he really described some of the concerns I have with this measure nicely. Unlike the prior measure, which I thought focused a little bit more on the clinician's surgical performance, I worry that this one places a lot of burden on patients and will punish health systems that disproportionately care for people who may have low health literacy or high economic needs. There are so many reasons that patients get readmitted, and there are so many confounders. And I do worry that social determinants of health are an important confounder that this measure does not adjust for. So I would not be in support of this measure.
Thank you. Appreciate that reflection on social determinants. Akeen, you have your hand up.
I do. I think David and Devika really emphasize a lot of the same concerns that I had, but I actually have more of a clarifying question. As I look at this measure, it says readmissions within 30 days of a readmissions with a 30-day window. Does that imply that the principal procedure is being done on an inpatient basis, or does that include both inpatient and ambulatory procedures? Could you say a little bit about that?
I think we can send that to the measure steward.
I'm sorry, can you repeat that? Because I missed part of it.
Yeah, so as a readmissions measure, is this looking at, does that mean that the principal procedure that's done to begin the measurement period, does that mean that all of these principal procedures are done in the hospital, or are some of them ambulatory surgical procedures too?
I am validating through our CPT codes just to be sure. And I may need a moment just because I don't want to answer incorrectly.
While we're waiting for that response, just want to note that Carla put a note in the chat that she agrees with the comments related to social determinants of health. Carla, did you want to expand upon your comment?
Just something that our team talked about here when looking at the readmissions measures, that they're important for care transitions. We don't disagree with that, but it also, there's some caution that if somebody needs to be readmitted, they should be readmitted if that's what's best for the patient. And it can potentially set up sort of incentives to try to avoid readmissions, even though that might be what's best. Again, we have a lot of focus on rural, and a lot of times the resources that might be available to support that patient in a rural community might be less than what you have in an urban community. So just making sure that we're both focusing on what's best for the patient, and that might be a readmission.
Thank you for that. Jessica, did you have your hand up for a different comment?
Apologize. No, I just meant to put it down.
No worries at all. Rosie.
Well, I guess I agree with all of what's just being said. And I really, I've lived this readmission and, policy multiple times over the last 15 years. And, I really, the one before I could get behind because it was, I was readmitted, or I was had a reoperation and multiple reoperations because of a field operation. But this just, I'm afraid we, even as I talk with healthcare systems, they talk about, the readmission is related to social determinants of health. And then I worry about, do we find loopholes or look for loopholes? And, and I hope not, but, but it's, this is, it's not clear enough. And I just think we need to be clearer on this.
Yeah, thank you.
So with
go ahead. Yes, Erica.
Oh, sorry, go ahead.
Oh, sorry. I was going to see if Erica wanted to get back to the coding question first. But Lisa Marie, why don't you go ahead if you're ready?
So what I was going to say with regard to the comments is measures not accounting for, let's say, risk adjustment relative to SDOH elements. And those are things that we are wanting to incorporate more within our measures. So not only just having like SDOH measures or like health equity measures, like standalone, but also having those elements in the measures. So some of these measures have been in our program for several years, and so they may not have those particular elements. As someone noted previously, you know, in developing a measure, it takes a lot of time and a lot of resources and money. So, but as we are now with health equity being a high priority measure for CMS, this is something that we want to incorporate in our measures. So not only having separate measures, but having those elements included in the measures. So I just wanted to highlight, because I'm seeing a lot of comments relating to those dynamics there.
So let me say sort of slightly differently what Lisa Marie just said, is that we're just starting to collect SDOH measures, and I get my years mixed up whether it's voluntary and mandatory. But identification of social determinants of health is, I think it's this year, is mandatory for the first time. So the elements that you say are important, that information hasn't really been available to us until right now. So I think you might imagine or anticipate. I'm not giving away the information. I'm just thinking out loud that once we have that information, we might go back and change these measures a little bit. But right now, we don't have the data to do that. That's part of the reason for collecting that information, so we can come back to you guys in a year or 2 or 3 and say, well, now we can combine the two together.
Okay, I'm seeing a lot of agreement in the chat that social determinants of health should be included in risk adjustment for all readmissions measures. Lots of encouragement for CMS there. Sai, yes.
Hey, Meredith, just a quick clarifying question. I think when this measure was introduced earlier, I heard there's no risk adjustment at all. It's not just the SDOH portion, right? Because if it's just SDOH, you know, to Ron's point, we're not quite there to be able to adjust because of the data availability issue. But if it's not adjusted at all, I think that to me, it really raises some serious concerns, right? Our other readmission measures that I know of adjust for discharge conditions, comorbidity, demographics. So I think at the basic level, this measure needs to have some adjustment for the patient mix.
Yeah, thank you for that. It's not just SDOH. There's no risk adjustment for other factors either.
And I can speak a little bit. So the care setting does say that it's acute care facilities or hospitals, but because of the CPT codes, I can't, 100% say whether or not where the procedure is performed, whether or not it is only within hospitals or ambulatory.
Okay, thank you for that clarification. So we've just to kind of summarize the discussion we've had thus far, we've been talking a lot about this measure and other readmission measures potentially missing part of the story, whereas they do not risk adjust for social determinants of health or other characteristics that might be important to consider as potential confounders. Though I think there's support for the idea of coordination and patient safety that this measure sounds like it could be improved upon with additional risk adjustment. Did I miss anything that anyone wanted to raise with regard to this measure?
Hi, this is Jill from the College of Surgeons. I just wanted to respond just more broadly. I think that this measure we really need to think about sort of like, what does the future of the MIPS program look like? because these, you know, we're the measure steward, but we recognize these as sort of measures that are outdated for what we think we should be focusing on in terms of moving toward value-based care. I mean, I think a lot of the specifically this measure, but like more generally in the NIPS program, it's really kind of not fit for a proceduralist. There's low rigor, not very valid. Like these types of metrics in general are really kind of pitting individual clinicians against each other, really focusing on the specialist versus looking at the episode or the procedure. So, you know, I think there was recently, CMS is really looking into sort of how to invest and build out on patient-reported outcome measures. I think that is probably a better direction and focus for the MIPS program versus these adverse events, which are very rare in the hospital, let alone sort of reporting on the individual level for the MIPS program. I know when we had this measure in our registry and we ran it, it was, and this was many years ago, but this is when we sort of weren't able to have risk adjustment included in the measure, and we're kind of trying to make the case that it really needed to be in there. There was, the misclassification was so high that it's just, this is just broadly speaking, these sort of rare adverse events are, in our opinion, not really fit for this type of program. So just making a plug for, you know, thinking about how to get the resources to invest in more measures. Another huge part of it is a lot of measures are being removed from the program, but there aren't the resources for new measures. And so I think people are reluctant to let go of some of the older measures because then they will have very limited options to report on to participate in the program in general. So just wanted to give that perspective as well.
Thanks for that, Jill. Were there any other, oh, Jessica, yes, go ahead.
Just a comment and a question. If there's ever opportunities to perhaps, instead of thinking about risk adjustment alone, stratifying by social determinants of health measures so that could incentivize improvement in subgroups as opposed to risk adjustment alone.
Yeah, I think that's great feedback. Again, for CMS to consider stratified reporting is an important way to see where the disparities exist. So thank you for that, Jessica. Are we ready to move to a vote on this measure?
I think so.
You think so? Okay. And Akeen?
Akeen, what do you think?
I agree.
Okay. Let's do it, Isaac.
Voting is now open for the measure on unplanned hospital readmission within 30 days of principal procedure. Do you recommend the continued use of this measure in the merit-based incentive payment system? The options are A, yes, continued use, or B, no, discontinue use. And we are expecting 22 votes. Correction, we're expecting 23. We have all 23 votes. Voting is now closed. We have 9 votes for continued use and 14 votes for discontinued use. With greater than 50% voting for discontinued use, the committee recommends the discontinued use of the measure in MIPS.
Okay. Thanks so much, everybody. And I think we just have a couple of measures on the docket. Brenna, I think you are picking up from here.
I sure am. Hi again, everyone. So just to reorient everyone, we are taking a step away from the MIPS program, and now we are looking at the Part C program. So we are looking at the plan level all-cause readmissions measures. So the measures that we've been looking at up until now have been largely at the clinician level. These will be at the health plan level. So that may change some of the interpretation of the measures. And if you have questions about that, as we discussed, please don't hesitate to bring them up. So let's go ahead to the next slide. So we're going to start here with plan all-cause readmissions. So this is looking at the percentage of plan members over 18 and over discharged from a hospital stay who were readmitted to a hospital within 30 days, either for the same conditions as their recent hospital stay or for a different reason entirely. Patients may have been readmitted back to the same hospital or to a different one. The rates of readmission take into account how sick patients were when they went into the hospital the first time. And this risk adjustment helps to make the comparisons between their plans fair and meaningful. This measure is stewarded by NCQA, and it is used in Medicare Part C star ratings. It is an outcome measure, again, at the health plan level of analysis. It is not endorsed. It does not meet a statutory requirement, but the data elements are collected as part of a normal clinical workflow. So for this one, I'm going to turn it to Liz Goldstein and Lauren Popham from CMS to talk through the role in the program.
Thank you. I'm going to start by giving some background. The plan all-cause readmissions measure is a long-standing Part C star ratings measure. It assesses the number of acute inpatient and observation stays during the measurement year that were followed by an unplanned acute readmission for any diagnosis within 30 days and the predicted probability of an acute readmission. It is for all Medicare Advantage plan members and is risk adjusted for age, gender, comorbidities, and index hospital stay discharge condition. The measure excludes members in hospice and planned readmissions. Measure rates are reported as observed to expected ratios, with lower rates indicating performance that was better than expected. Due to a substantive specification change, this measure was temporarily removed from the star ratings and placed on the CMS display page. It returned to the Part C star ratings for the 2024 star ratings, reflecting the 2022 measurement year. Changes by NCQA included adding observation stays and removing individuals with high frequency hospitalizations. CMS also added the under 65 to this measure for star ratings and increased the denominator from 100 to 150. I just want to give a little kind of background about our rationale for including it in the program. Studies have shown that unplanned readmissions are common, costly, and are associated with negative health outcomes, particularly for older adults and adults with multiple chronic conditions. Many of these readmissions are avoidable, and health plans play a critical role in improving the quality of care transitions, reducing the rate of readmissions, and improving health outcomes for patients. This measure serves as a tool to track and monitor readmissions among health plans and target interventions where needed. CMS has included this measure in the Part C star ratings program since the basis of the MA program is for MA contracts to coordinate the care of their enrollees. MA contracts are responsible for coordinating care following a hospitalization and to ensure that their enrollees are receiving appropriate care. Currently, there's variation in scores ranging from 3 to 18%, so there is room for improvement. Given the prior conversation, I just wanted to also add that we do provide confidential stratified reports back to health plans, and it's stratified by dual eligible and low income subsidy status. So measuring the low income versus non-dual eligible and low income subsidy status, as well as we provide stratified reports by whether the enrollee is disabled or not. And disability is defined by original reason for entitlement to the program. So we do provide that information to help plans for quality improvement. This measure also, once we implement a health equity index reward with our 2027 star ratings, this measure is included in that. So there again, contracts will be rewarded if they do well for low income and disabled enrollees for this particular measure. This is one of many measures included in that index. So I'm going to turn it back over.
Thanks, Elizabeth. Let's jump to the next slide, please. Okay, so for the plan all-cause readmissions measure, we've got a little bit of mixed feedback, but largely supportive from the PI forms. There is an indication that the measure improves transparency for patients, and that that 70% of entities have reliability of 60% or higher, which is relatively strong. There are some concerns around the lack of performance data prior to 2022, which limited some folks' review of the measure. So there may be some questions there as we get into the discussion. And there were some folks that had some questions, seeking clarity on how the measure score is actually calculated. It's a little bit complex. Having said that, folks felt that this measure was patient-centered and reflected the patient journey, and that it improves transparency for patients and aligns with an overall desire to avoid readmissions. And folks generally felt like data collection and reporting for this measure is relatively low burden, and that this measure has a unique focus among other readmissions measures in similar program measure sets. So we can go ahead to the next slide. So the PI inputs were overwhelmingly positive, and we didn't really receive any public comments on this measure specifically, but I know we just had a very robust conversation on readmissions measures in general as it related to the MIPS program. Understanding that readmissions measures look a little bit different when we're doing it at the plan level and when that information is publicly reported. Just wanted to open the field here for the committee to either ask questions or to share their perspective. Do folks have concerns about the plan all-cause readmissions measure? Go ahead, Devika.
I would just say same kind of similar concerns as before for me. I'm a little bit unclear about how this measure is different in terms of it not being attached to a health system and attached to, did you say an insurance plan?
Either health plan level.
Health plan.
It's at the Medicare Advantage health plan level.
So that means that this measure only applies to people who are a part of that health plan.
Correct.
Noted. I'll just say my concerns are the same, and I just shared I think what could be seen as a helpful viewpoint on how we look at hospital readmissions as a quality metric in general.
Thank you. Corinne, I see your comment in the chat. I believe it's meant to be in response to Devika, but could you expand on that?
Yeah, what Devika's saying, it de facto is a provider, whether physician or hospital measure, because anything that's clinical related the information's calculated through claims, and from what we've seen, the plans then apply those metrics in contracts to the providers. And the higher the cut points are, the stricter the plans are in terms of paying for or denying care, because they can't obtain their star ratings and their bonuses if the providers aren't performing well.
That was really helpful. Thank you, Corinne.
Go ahead, David.
Yeah, so I generally agree with Devika and Corinne. Great comments. In theory, at the highest level, I'm least bothered by the health plan, who can ultimately be more responsible overall for the more continuum of care of the patient in the 30-day period. That being said, and as Corinne said, like really well, is ultimately it comes down and is really penalizing the clinician or the hospital and not the health plan truly engaging and really helping to improve patient care. So I think that although the intent of pushing the right performance, I think this measure has unintended consequences, and in fact then falls even more out of control of the provider or the hospital, and then all the other issues. Although I'm glad this at least had risk adjustment in it, is problematic.
Okay, thank you. Go ahead, Sai.
Hi, thank you. Hi, Liz. Nice seeing you here. Quick question about, you mentioned that CMS share the stratified results back to plans for SNP members and DSNP members or not. I think not everyone on the call is close to those technical jargons for MA plans. Can you just expand on that and what you see? I think where I'm going with is what we see here is members with higher social risks tend to have higher readmission rate. And we had a lot of discussions earlier and in the chat that the social SDOH is not included in risk adjustment for any of the readmission measures. And if you can comment on what the future plan is, that would be very helpful.
Right. So what we include, it's not just dual SNP, but it's anyone who has Medicare and Medicaid coverage. Those are dual eligibles. And anyone that is included that qualifies for the Part D low-income subsidy. So that's our group of low-income individuals that we can easily measure in the Medicare program. So we provide that information, stratified reports, back to health plans so they can target their quality improvement activities. But for across all the Part C and D star ratings measures where we have patient level data, we will be implementing starting in the 2027 star ratings, and it covers the 2024 and 2025 measurement years. For each of these measures where we have enough data, we're going to calculate scores just for those groups of enrollees, so low-income enrollees and ones that are disabled, and look at how their performance differs across contracts. And basically, if you have high performance across the various measures included, you'll qualify for a reward. It's a small reward. It's an increase to your star ratings, but it's really to incentivize Medicare Advantage and Part D contracts to really focus on these populations, not just for this measure, but for all of the star ratings measures, and to, target their attention to these populations, and they will get, a little reward in their star rating if they do well serving these populations.
Thank you. Sean.
Yeah, it was my understanding when I read this that we're talking about a plan level measures.
Correct.
Okay, so this is at the plan level, because at the plan level, sometimes you're going to have a readmission that's even in a different hospital with a different provider. And so I'd say this is not as trackable to the individual. The plans may have contracts with providers or provider groups that talk about readmission levels and those sort of things. But this particular measure I was taking as being at the plan level to compare plan to plan readmissions.
Yes, it is. And it's really targeted because plans have an opportunity to avoid unnecessary readmissions. Obviously, there's always going to be necessary readmissions, but if they coordinate care, make sure that their enrollees get the follow-up care that they need after a hospitalization, it should help minimize, obviously not get rid of, but minimize the readmission. So I think that's why it's critical. The whole premise around Medicare Advantage is that care coordination. And so this is an area where after an enrollee has a hospitalization, they should be coordinating care, jumping in, seeing what that enrollee needs, making sure they get the follow-up care. So trying to avoid readmissions where that can be basically avoided. So I do think it is, I know there are concerns coming from the last conversation, but I think this is a different type of readmissions measure, and it's really focused more on, are the plans doing everything they can to prevent readmissions for their enrollees?
Thank you.
Thank you all. All right, I'm going to summarize the discussion up until this point. If that summary prompts additional comments, we can continue the discussion, and if not, we can proceed with the vote. But here's what I am hearing. It is that there is general agreement that health plans do play an important role in managing readmissions, and that because this measure is tracked at the plan level, it allows for addressing care coordination issues in a way that's not as possible with a clinician level measure, which means that it actually promotes practices that might reduce unnecessary readmissions. The measure is stratified by dual eligibility status, and it is risk adjusted, which addresses concerns that were raised in the last discussion. And we heard from several people on the line that they are in general less bothered by plan level measures, but ultimately that the potential unintended consequences associated with disincentivizing necessary readmissions still stands. Did I miss anything from the discussion, or does anybody feel like something that they wanted to highlight was not there? Go ahead, Devika.
Just added in the chat that, not all readmission is related to care coordination. So just something to keep in mind. We all know that, but just emphasizing that.
Yep, and I think so the balance there is trying to think about the extent to which the improvement on the measure is within the control of the plans and the extent to which it is not. Okay, I'm not seeing any additional hands following that summary. So if it is okay with Rosie and Akin, I am going to open this one up for a vote.
It's okay with me.
Thank you. All right, go ahead, Isaac.
Voting is now open for the measure on plan all-cause readmissions. Do you recommend the continued use of this measure in the Medicare Part C Star Ratings program? The options are A, yes, continue to use, or B, no, discontinue to use. We're expecting 23 votes. We have all 23 votes. Voting is now closed. We have 18 votes for continued use, 5 votes for discontinued use. With greater than 50% voting for continued use, the committee recommends the continued use of the measure in the Medicare Part C Star Ratings program.
Thank you, everyone, and thank you, Isaac. Let's move on to what I believe is our last measure of the day. So we are taking a step away from readmissions, as I'm sure everybody is really relieved to hear, and we are talking about MPF price accuracy. So this is measure 45201C Part D. Go to the next slide here. All right, long description, but I'm not going to get into the full details here. So what the MPF price accuracy measure is a score comparing the drug's total cost at the pharmacy to the drug prices that the plan provided for the MPF website. So higher scores indicate better performance by plans because it means that the plans provided more accurate pricing. The measure is a composite score that factors in both how much and how often the prescription drug prices exceeded the prices reflected on the MPF tool. I'm going to stay here and just let people read for a moment instead of talking at you. Okay, we can go to the next slide. So this one is stewarded by CMS. It is in the Medicare Part D Star Ratings program. It is a process measure at the plan level, at the Part D plan level. It's not endorsed and it is not part of a statutory requirement, but the data elements are collected as a part of a normal clinical workflow. So with that, I would like us to once again turn it to Liz Goldstein and Susanna Scanlon for some context around this measure.
Okay, I'm going to start. The Medicare Plan Finder Price Accuracy Measure evaluates the accuracy of drug prices submitted by Part D plans for CMS to post on the Medicare Plan Finder tool on Medicare.gov. So the Medicare Plan Finder tool is a tool that anyone selecting a Medicare plan can use. They put in basically their zip code and all the plans in their area pop up. And this is one of the measures on that tool. Medicare beneficiaries use this tool to compare and enroll in a Medicare Advantage prescription drug plan or standalone prescription drug plan. We developed this measure to help ensure plan sponsors submit accurate prices to support beneficiaries' informed decision-making. This measure evaluates the performance of Part D plans at the contract level. It evaluates the accuracy of the drug prices on the Medicare Plan Finder tool by comparing them to the actual cost of the drugs at the pharmacy. Drug costs at the pharmacy are obtained through the Part D plan's prescription claims or prescription drug event data. The measure is a composite score of two indices to represent how much and how often a plan's prescription drug event prices exceeded the prices shown on the Medicare Plan Finder tool. We calculate the accuracy index, which we call the price accuracy score, which is the amount that the prescription drug event price is higher than the Medicare Plan Finder price, and the claim percentage index, which we call the claim percentage score, which measures how often the prescription drug event price is higher than the Medicare Plan Finder price. A plan's Medicare Plan Finder price accuracy score is the average of these two indices. The ingredient drug cost and pharmacy dispensing fee are included when comparing the Medicare Plan Finder and the prescription drug event prices. Prices only account against the plan if the prescription drug event price is higher than the Medicare Plan Finder price. Instances where the prescription drug event price is lower than the Medicare plan finder price do not count against the plan score. Higher scores indicate better plan performance because they mean the plans provided more accurate prices for the Medicare plan finder tool. Medicare Advantage prescription drug plans and standalone prescription drug plans are measured separately. The measuring period, as was on the prior slide, is January to September in the calendar year. The 2024 scores for this measure vary from 62 to 100. Thus, there is room for improvement. However, the mean score is fairly high at 97, indicating that most Part D contracts do quite well on this measure. I'm going to now turn it back.
Thanks, Liz. Let's go to the next slide. Okay, so in general, we got a fair amount of support for this measure. So on the public comment side, there's just agreement that it's important for patients to have access to accurate drug costs. The support really stemmed from high performance in the years that have performance data. And in general, this measure seems both important and usable. There were some concerns about the potential to game this measure, and just overall concern that although this addresses, drug price transparency, it doesn't address overall plan affordability. And they also raised some concerns about barriers to usability. But in general, folks felt like this measure improved transparency for patients, and that there was minimal overlap between this measure and others, alongside low data collection and reporting burden, making this, a parsimonious addition to the portfolio. And let's go to the next slide. And so, we can start wherever folks want to, but as always, the discussion question that we put here is really just, the goal of this measure is really to increase transparency about drug pricing and to incentivize plans to share accurate drug pricing information on the Medicare Plan Finder website, which it seems that members and the public agree is important. So the question I think up for discussion here is whether or not the measure is achieving that goal. Go ahead, Michelle.
Thanks. This is one of the measures that I reviewed, and I did have the concern around gameability. So this is a measure I was not familiar with before this review. And so I'm curious, what controls are in place to ensure that Medicare Plan Finder price is an accurate representation of price? Because if that is the index, then I could see how this measure would be very gameable, make the Medicare Plan Finder price higher than your intended sale price, and then you'll never be dinged on the measure. So I'm wondering if that's the case, and if there's any way to prevent like an inverse incentive of listing too high a price as your Medicare Plan Finder price.
Yeah, thanks for that question. So CMS, I guess I'll turn it to you.
Susanna, do you want to address that one?
I guess in terms of the star rating for this measure, perhaps there's not an inverse. However, I would say that, part of the point, and others can add on to this, but part of the point of beneficiaries going on to the Medicare Plan Finder tool is to pick the drug plan that they want for the next year. And one way they may do that is by putting in their prescriptions and determining the price of their prescriptions. They can compare the prices. So, one thing that plans would probably consider is that if beneficiaries see that the price for their drug at their plan is higher than others, the beneficiary may not enroll in the plan. So that's just one thought I have about, why might the plan not necessarily want to put like a higher, an inflated price? But if there are others at CMS who have other comments, please let me know.
Yeah, I agree with that. I mean, a lot of Medicare beneficiaries, in particular for standalone prescription drug plans, you can enter, as Susanna said, all of your drugs into this tool, and it pops out what is your expected cost. So if they inflate it, it's less likely someone is going to choose your plan. In particular, for a prescription drug plan, those costs play a big role in, which plan will you choose. So they haven't.
Yeah, and I'm sorry, I
do that.
Go ahead. Sorry, Liz, I thought you were done. I just want to add one other thing. Thank you, Alice, for reminding me that while this isn't a STAR measure, we have something else called display measures, which are measures that are sort of informational. They don't count towards STAR ratings, but they are posted publicly, and there actually is an inverse measure. It's sort of the inverse of the STAR rating, where it counts against the plan if they post higher prices on the plan finder tool, and then the actual price at the pharmacy is lower. So we do actually have a measure for that, and it is posted. The plan's scores are posted publicly. However, it's not a STAR measure. So I guess just to say the information is out there.
Hi, everyone. This is Alice Lee Martin. I'm with the CMS team, and I'm so excited. I got promoted to be a panelist as well. So I'll just add on, and Susanna and Liz have definitely given context, but we certainly would want to watch out for that potential gaming. This is, as Susanna mentioned, the countermeasure is on display, and we have to date not seen any activity that we thought would be problematic from the sponsors' side. We've been asked by others within the government, of course, to be looking out for that kind of potential discriminatory behavior, right, to try to dissuade people from enrolling. So we share your concerns, and I think we do have safeguards for that.
Great. Thank you, Michelle, for kicking off that discussion, and thank you to all the folks from CMS for chiming in with that context. Akeem.
Thanks. And Michelle's questions around gameability are well-founded and really good ones to put on the table. I guess I have a broader contextual question that speaks to the value of the potential value of this measure from a patient perspective. Do you have a sense of how frequently that pricing tool is being used on the Medicare Advantage Plan website? That would be helpful for potentially knowing just how much usability we're getting out of this.
Yeah, I think that's a question for CMS.
Alice or Michelle, do you know offhand?
We can try to find that while we're on the call. We're all looking for that data. The latest, I know for sure, most popular window is Thanksgiving week. That our Office of Communications have definitely confirmed every year that's the most popular. But I would love to give you a statistic of how many, or basically a percentage of enrollments and where if they stem from use of the Plan Finder tool. So can we come back to you on that question?
That'd be great. And I know that we have a number of patients who are part of this group. So if you've had any experience with that particular tool, would love to hear it.
So this is Michelle Akeen. I've never actually seen data on it. Liz, do you have any? And we'll check into it. It's a good question.
Yeah, we're checking to see how, the numbers, that's what Alice is trying to find. I think a lot do use it. I think that's kind of the common way where folks do enroll for a health plan or drug plan. For patients that have not used it, in particular, if you're choosing a drug plan, it's super useful in entering all the drugs that you use and coming up with, what is it going to cost you in the coming year? I know I always use it for family members. It's very useful.
Thanks for that question, Akin, and thank you to all the folks at CMS that are looking to track that information down. If the conversation is kind of rolling on if you find that info, go ahead and just stick it in the chat and then we'll bring it up when we see it. So Rosie, go ahead.
Well, I've used it, and I guess right now as Medicare is the time for changing enrollments, and that every day there's something in the mail from every organization or every insurance company telling you that go on this finder and you can find out what we charge for drugs. But the other thing is that I've been working with a hospital about readmissions, and when we made a lot of phone calls to people that were readmitted over the last 2 years, we found out that many of them didn't get the prescriptions refilled because when they got to the pharmacy, they found out that the copay was extremely high. So we now are like trying to educate patients that when they get a new prescription like this, before they even leave the hospital, or at least the families will research it so that they get the prescription refilled rather than not get the prescription refilled and end up in a readmission because they never took the prescription that they needed or were started at the hospital. So there's a couple different uses of it, and for me it's the transparency, the fact that, and I guess I didn't think about gameability, but I guess that you could play games with it, but in the end it's going to hurt patients if you do that, and yet it really could be a real tool, not only for I know we didn't want to talk about readmissions anymore, but it could be a real tool for helping reducing readmissions, because when you bring the pharmacists in, the pharmacists are always going to tell you that many times the prescription gets left because the copay is too high.
Thanks, Rosie. It sounds like an endorsement of the transparency and as it relates to patient care. Go ahead, Corinne. Corinne, if you're talking, you're muted.
Oh, yeah, sorry. We'd support maintaining the measure. I think anything to shed light and increase transparency on drug costs is helpful. There's limited information out there when you get to the point of care. And so if we can be more proactive as this measure does, hopefully it can better assist and steer patients with medication adherence and affordability. Thank you.
Yeah. Okay, since I'm not seeing any more hands at the moment, I'll summarize where we're at for now. Basically, we heard an initial discussion talking about the potential gameability of the measure. We sort of heard that it's a little bit self-limiting, just given the purpose of the MPF, the idea that purposefully inflating prices would potentially disincentivize people from selecting the plan, and that also there are countermeasures that are on display. So there are measures in place, and this is something that the program is tracking. We heard Akin's question about the usability stats on the MPF tool. We're still waiting on that feedback. The implications of that being that if it's widely used, then that tells us that this has potential high usability. If it's not widely used, it's not necessarily associated with any negative unintended consequences, just potentially that the measure has less ability to impact the patient experience. And then we heard a great example from Rosie on sort of the use case for this for patients and how this tool has been important both to her personally and to people that she knows. And that this measure may have some other application, not this measure, but the use of, sort of a transparency measure can have implications across the board. And then we heard from the AMA that they generally support maintaining the measure, largely because anything that drives transparency to patients about drug prices is beneficial, especially given the limited information at point of care, and that this is a more proactive approach. Did I miss anything, or are there any other discussion points that folks want to cover before we take this to a vote? Go ahead, Ethan.
Yeah, I just had one question for clarification. It sounds like this measure only factors in when the actual price of the drug exceeds that they had originally set or predicted. If the ends up being lower, it seems like they're not penalized through this measure, right? And I guess my only other question is, like, does this measure somehow incentivize a plan not to try to make the actual cost of a drug lower, or, because then they're just trying to hit their initial prediction of how expensive the drug will be. So I guess I was just trying to get some clarification around that.
Does CMS or the measure developer want to talk about how the measure is scored vis-a-vis those whose prices are lower than what's on the website?
So Alice or Susanna?
Well, I guess I'll reiterate that this particular STAR measure plans are only penalized for when they post a price on the Medicare plan finder that's lower than what the patient actually, than what actually happens at the pharmacy. So for this particular STAR measure, right, that it's only penalized when the price posted on plan finder is lower than the actual price in reality. I hope that answers your question, but if not, let me know.
It does. Thank you.
Okay, I don't see any other hands raised, so I'm going to look to Akeen and Rosie. Rosie's shaking her head yes. Akeen, you're good with the vote? Great. All right, then Isaac, let's bring this one to a vote.
Voting is now open for the MPF price accuracy measure. Do you recommend the continued use of this measure in the Medicare Part D Star Ratings program? The options are A, yes, continue use, and B, no, discontinue use. And we are expecting 23 votes. Waiting for 3 more votes. Waiting for 1 more. All right, we have all 23. Voting is now closed. We have 23 votes for continued use and 0 for discontinued use. With greater than 50% voting for continued use, the committee recommends the continued use of this measure in the Medicare Part D Star Ratings program.
Thank you, Isaac, and thank you, everyone. We can go to the next slide. So we have wrapped up our voting for day 1. We'll pick up tomorrow. I'm going to turn it to Meredith to talk about next steps, but before I do, I just wanted to thank you all so much for your participation and attention today. We never lost quorum, which is wonderful, and really helps make sure that this process runs smoothly and it really maintains the integrity of that process. So thank you all for your participation. And with that, Meredith, take us through our next steps.
Yeah, thanks, Brenna. Before I talk about what happens tomorrow, I did just want to get back to a question that Corinne, I believe, had raised when we were talking about the MIPS readmission measures. There were two, I believe, readmission measures in MIPS. One is the unplanned hospital readmissions within 30 days of principal procedure measure, which we did discuss today. And the other one is the hospital-wide all-cause unplanned readmission measure, which we did not discuss today. And looking back at our records internally here, we did prioritize the unplanned hospital readmissions within 30 days of principal procedure because it really has an inference of a direct causal association between that principal procedure and the readmission. And that inference was challenged by a number of potential confounders, a lot of which were discussed by the committee today. Whereas the hospital-wide all-cause unplanned readmission measure is a more general inference of causation, so where readmission could be attributed to access, quality, community resources, any number of factors, but it doesn't attempt to draw that inference. So that's why we prioritize that one measure over the other. I don't think that information would affect anyone's vote, but did want to provide that clarification on the process, and we will have time tomorrow to talk about kind of what sorts of information would be helpful to committee members throughout the MSR process. So feel free to add to questions or comments about how we prioritize measures tomorrow. But speaking of tomorrow, we are going to reconvene at 10 a.m. Eastern to pick up on our next set of measures. Tomorrow we're focusing starting on hospital and ambulatory surgical center measures. We'll start at 10 a.m. Eastern. Use this exact same link that you used today. So just use that same link and we will kick things off promptly at 10 a.m. And I just want to thank you all again for your time and attention and the great discussion today. So have a wonderful rest of your day, and we'll see you tomorrow.